So what we see in this degeneration, we can see loss of intensity of the disc and loss of disc head, and sometimes we can find sporous node. And for central spinal canal stenosis, we can see there is a posterior osteophyte. We see there is also OPLL, buckling or thickening of the yellow ligament, and that causes a cord compression. And we can also find some intramedullary lesion that caused by cord compression. And according to the classification of central spinal canal stenosis, you can find there's a mild central spinal canal stenosis. There is no compression of the spinal cord and no intramedullary lesion. And with moderate central spinal canal stenosis, we can see there is slight compression of the anterior aspect of the cervical cord, this part, and there is no intramedullary lesion, but with a severe release of the disc head. And in type 5, there is this degeneration with an inhomogeneity, hypointense, and also severe decrease of disc head. And according to this modified Friedman grading classification by James Griffith, so we have 8 types. We can see from the grade 1, grade 2, this is a still normal, this slight hypointense but still normal disc head, and this one still normal disc head but slight hypointense, this still normal but inhomogeneous and hypointense, and here we can see there is a slight decrease, this moderate, severe, and this is the most severe decrease of this head. And how about this dynamic contrast enhanced MR perfusion for this degeneration? First, we can see vertebral marrow perfusion. This correlated well with intervertebral disc degeneration that evaluated with dynamic contrast enhanced MRI. And there is also changes in perfusion and diffusion and the end plate regions of degenerative disc. So what we see here, this publication about intervertebral disc degeneration that related to reduced vertebral marrow perfusion and dynamic contrast enhanced MRI. And also these changes in perfusion and diffusion and the end plate regions of degenerating intervertebral disc in dynamic contrast enhanced MR study. So what we see here, this is the normal disc with a normal end plate. We can see this difference between this one and this one with the disc degeneration and the end plate, the dynamic contrast enhanced MR perfusion. So we see in time curve intensity, we can see decrease of this dynamic contrast enhanced perfusion. And also in the disc space, this is the normal disc, and there is a disc degeneration with inhomogeneity, hypointense, and also decrease of this head. We can see the time curve also decrease. And then for TTI, for spinal cord evaluation, we see T2 hyperintensity with fluid intensity. This consistent with myelomalacia, and this irreversible. And stenosis classification not always correlate with the patient's symptoms. TTI with fractional anisotropy and mean diffusivity could detect the microstructures abnormality of the spinal cord. So what we see in this OPLL, this herniation, posterior osteophyte, so all of this can cause central spinal canal stenosis. And we have the grading system of grade 1, this is a mild, and this grade 2 moderate, And grade 3, this is the severe decrease, severe compression of the spinal cord. But in grade 2, there is no spinal cord abnormality, but what we see in TTI with fractional anisotropy and mean diffusivity. So what we see in this C5-6 level, when we compare to the normal side of C1-2 level, so we can see this one, the fractional anisotropy and C5-6 level, when we compare to the C1-2 level, this decrease of fractional anisotropy and increase of mean diffusivity, though there is no spinal cord abnormality. So we can also see for the nerve root compression, a new MR grading system for cervical foraminal stenosis based on axial T2 with 8 images. So what we see here, this is a normal nerve root, there is no compression. There is also still normal nerve root without compression, but this is a grade 1. There is a compression of the nerve root, but less than 50% when we compare to the nerve root that exit from the foraminal area. And this more than 50% compressed, this is a grade 2 nerve root compression. So this one, this is grade 1 nerve root compression that less than 50% when we compare in this side. And here we see there is compressed more than 50% when we compare to this side. And how about TTI with tractography for evaluation of nerve root compression? TTI with tractography, so this from the conventional MR we see there is impingement of the nerve root, and what we see here, there is also kind of sign of the tractography here. We see there is a tractography that there is a nerve root compression here. So at last, we come to the take-home point. Conventional MRI shows the anatomy evaluation of degenerative spine, and dynamic contrast enhanced MR perfusion for investigate the etiology of this degeneration. TTI with tractography can predict the neurological severity, thus making it a potential tool for the functional diagnosis of nerve damage. Thank you.
Thank you, Dr. Andriani. Now I would invite the next speaker, Dr. Elsanti Dewi Martandini from Indonesia. She will be speaking on cervical trauma imaging. Dr. Elsanti.
Thank you, Mr. Chairman. Assalamualaikum warahmatullahi wabarakatuh. First of all, I would like to thank for the committee and especially Dr. Khalid for the hospitality. I would like to talk about cervical trauma imaging. And this is the review of my talk. Okay. First, we talk about cervical spine stability. This is important, and if we talk about cervical stability, we have to remember again about several lines and several structures, including anterior vertebral body line, posterior vertebral body line, spinolaminar line, and also posterior spinos line. This line should be in a good alignment. How about these spaces? These spaces have to be symmetric, no widening or narrowing anteriorly or posteriorly. And then how about the interspinos and interlaminar distance? It should be demonstrate little variation. In this picture, we also see the normal spacing of the facet joint, which is parallel to each other, and also uniform facet joint interval. So, signs of instability in cervical trauma is involvement of more than one spinal column, disruption of the posterior vertebral line, vertebral body subluxation, and loss of vertebral body height greater than 50%, and if there are any presence of kyphosis greater than 20 degrees at a single level. Now we move to mechanism of trauma. There are several mechanisms, and usually each mechanism may be associated with other forces. So the injury pattern becomes more complex and sometimes difficult to determine the classic trauma pattern of each mechanism in this combination of trauma mechanism. We know that there is a bending forces like hyperextension or hyperflexion or lateral bending, and then compression or axial loading, tension or distraction, torque or rotational injury, and auto shearing. Now we move to axial loading injury. The common trauma is diffusion fracture, same with burst fracture of C1. The mechanism is axial loading along the axis of the cervical spine. Then it will be the result of bone fracture of the anterior and posterior arc of the C1 vertebra. In this open mouth radiograph, we can see that there are bilateral lateral displacement of the articular masses of C1 that giving appearance of overhanging margin. And in the axial CT, there is a fracture of the anterior and posterior arc of the C1. Now we move to shearing injury. Usually happen in craniocervical dissociation. If there are any direct trauma to the skull such as the skull strikes the dashboard where the body is moving in a forward direction, thus creating a shearing forces at the craniovertebral junction. How to know about craniocervical dissociation? We can see that in this CT scan sagittal slice, there is a widening of the Bayesian and dense interval and also from Bayesian to posterior axial line interval that more than 12 mm. We also can see the V line that indicating the abnormal divergent nature of alignment of the anterior arc of C1 with the dense. And also we can see the increased midline spinolaminar distance of C1 and C2. This picture showed craniocervical dissociation. This part is anterior condylar displacement that separate the cranial and cervical part. And this one is separation of the craniocervical junction. We know that this is the type 1 and type 2 of craniocervical dissociation. Now we move to hyperflexion injury. There are several types of hyperflexion injury. Hyperflexion sprain, the mechanism is hyperflexion. Because of the hyperflexion, there are injury of the soft tissue of the posterior spine without any fractures of the bone. In wedge compression fracture, there are mechanism is hyperflexion and also axial loading that causing compression fracture of the anterior superior end plates. These injuries are stable if the fracture do not extend beyond the end plates and then less than 25% loss of vertebral body height and no sign of injury to the posterior ligamentous complex. This one is stable and this one is unstable. Facet dislocation is the result of the simultaneous hyperflexion and also axial rotation. So in this condition, the superior facet on the one side will slide over the inferior facet and it becomes locked, resulting in anterior subluxation of the upper vertebral body. It can be unilateral and also bilateral. So this one is the difference between unilateral and bilateral facet dislocation. In bilateral facet dislocation, the mechanism is more severe, hyperflexion and rotation. How about the anterior subluxation of the vertebral body? In unilateral, the anterior listhesis is less than 25%. In bilateral facet dislocation, the anterior subluxation is more than 50%. And in unilateral facet dislocation, the soft tissue damage is less than the bilateral one. And spinal cord injury can be happen or not in unilateral facet dislocation, but in bilateral facet dislocation is highly associated with spinal cord injury. And unilateral facet dislocation is usually stable, but bilateral is usually unstable. How about flexion teardrop fracture? If there are any flexion and compression, the compression and flexion will cause the teardrop fragment of the anterior inferior aspect of vertebral body and also retropulsion of the larger posterior part. Because of the hyperflexion, there will be widening of the facet joint and also interspinous distance. Now we move to hyperextension injuries. The often injury is hangman fracture. This one is a fracture through the pars interarticularis of the C2 because of the hyperextension force. Because of hyperextension force, the anterior longitudinal ligament is become injured and also anterior dislocation of the body of C2. And because the location is mostly in the anterior part, there will be a vertebral soft tissue edema also. Hyperextension with degenerative spine, and we have to also consider depression with degenerative spine. Because the patient with spondylosis has led to spinal canal narrowing, so a low velocity injury can lead to spinal cord injury. Extension teardrop fracture is happen because of the forced hyperextension, which the anterior longitudinal ligament will pull bony fragment away from inferior aspect of the vertebra and also associate with displaced anterior inferior of bony fragment. The fragment of the extension teardrop fracture is different with flexion teardrop fracture because of the extension teardrop fracture, the fragment is through avulsion, but in the case of flexion teardrop fracture, the fragment is caused by the compression. Sometimes if the extension force is too severe, there will be a buckling of the ligamentum flavum and it can cause the central cord injury. Now we move, the last one is Agssr fracture. If there any flexion combined with muscular contraction of upper body or neck muscle, the force transmission through the supraspinous ligament will cause fracture of the spinous process of the lower cervical vertebra. We call it Agssr fracture. Now we move to the cases. This one is man, 58 years old with motor vehicle accident. In the lateral CT, we can see that there is compression with teardrop fragment associated with vertebral soft tissue edema and also widening of the interspinous distance. Here we can see that there is a compression and also some facet subluxation in one side, and this one is widening of the interspinous distance. In axial images, we can see that there is a retropulsion of the vertebral fragment that causing canal stenosis and also laminar fractures and facet distraction in one side, but the other side is still preserved. So we make a diagnosis with the flexion teardrop fracture that are unstable. Case 2 is a male, 52 years old with motor vehicle accident. We see in the sagittal CT that there is an anterior listhesis of the C6 and also fracture of the spinous process and widening of the interspinous distance. From parasagittal images, we can see that there is a unilateral facet dislocation. We see that the facet is not in the right position, and in the other side, the facet is still preserved. MRI show that there is also injury of the anterior longitudinal and posterior longitudinal ligament. Diagnosis with hyperflexion injury with unilateral facet dislocation and traumatic disc herniation, which is unstable. The third case is a male, 57 years old with motor vehicle accident. In this case, the patient is a bit unfortunate compared with previous patient. In this part, we can see that there is prevertebral soft tissue edema with anterior traumatic disc herniation, also injury of the interspinous and also nuchal ligament, and also disruption of the flaval ligament, and also injury of the spinal cord. So, we make a diagnosis as a hyperflexion injury with traumatic disc herniation and spinal cord injury, which is unstable. Last case is a male 42 years old with motor vehicle accident. From lateral CT, we can see that there is an anterior listhesis of the C5, that the listhesis degree is more than 50%, and then also widening of the interspinous distance. On parasagittal image, we can see that there is a facet dislocation in the right and also the left side. Axial CT image confirm the degree of listhesis, which is more than 50%. And also we can see that this one is reverse Hamburger sign that represent the facet dislocation on axial CT. So we make a diagnosis with bilateral falcepal dislocation, which is unstable as well. So the take-home message is, knowing the mechanism of injury will be helpful to predict radiological findings of cervical spine trauma. Some cervical trauma mechanisms are combination of several trauma mechanisms, but a dominant force is usually apparent. And determine the stability of the involving region is important information for the clinician. Thank you very much for your kind attention.
Thank you, Dr. Desmitri. Now we come up with the last topic in the third session, afternoon session. It's my pleasure to present Dr. Tariq Sinar from Kuwait. Today's topic about the basic to advanced spine intervention procedure. Please, Dr. Tariq.
Well, first of all, I want to appreciate everybody who invited me to this conference, and I'm very happy to be here in Riyadh, my second home, and to share with you some of my experience in interventional radiology, especially treatment of spine disease. And I think this is a very important topic. It's a little bit different from imaging, but the reason I present this is because I think musculoskeletal radiologists are the best physicians who are qualified to do a minimally invasive spine intervention. First of all, I'm going to start with asking the question is, what is minimally invasive spine intervention? Well, it's a very, very long and complex subject. I was just talking to Dr. Bakr, who said that this is a subject that needs to be accomplished by itself. I'm going to try to just go quickly through the basic or an overview of what we do as a minimally invasive spine interventions. Okay, so the definition is that the treatment of spine pathology or pain using non-surgical or minimally invasive method is done under radiological guidance. We don't use usual anesthesia. The day case procedure is done in the cath lab or under C-arm, and is usually associated with minimum risk. The radiologist is the best. It can be done by anybody who's trained to do this, whether it's a neurosurgeon or orthopedic pain specialist, usually an anesthesiologist, or an intervention radiologist. An intervention radiologist is the best person, in my opinion, to do this because he's the one trained in radiological anatomy. He has a better view in understanding the pathology, as we heard from our colleagues about the degrees of stenosis and other causes and this disease. So they're more qualified to assess the radiological pathology and radiological anatomy. So they're more qualified to do a better job as an intervention. Now, you can't do a spine, minimally invasive spine intervention without actually, being able to be an orthopedic or neurosurgeon yourself. not just, you have to shift from just a radiologist into this. You have to be able to examine the patient properly, know all the signs of the set disease, disc disease, canal stenosis, all the pathologies that we talked about from a clinical point of view, not just radiological point of view. So we just don't treat the image, we treat the patient. So we have to assess the patient. And you can see that the image, I always do this when I present this to the neurosurgeons orthopedic, is that what do you do for that pathology seen on the left-hand side? You know, most of the pathologists and orthopedic neurosurgeons said, of course, surgery. You know, you can't, you know, what can you do to this minimally invasive? Well, it's not a question whether you can do minimally invasive. It's not. The answer is wrong when you say surgery. The answer, it depends whether there is a clinical deficit, neurological deficit, significant pain. We don't treat an image, we treat the clinical pathology. So the fact that there is a big sequestrated disc is not necessarily that something that needs immediate intervention or surgery. So, a long time ago, before I started this, 21 years ago, okay, all that was available for treatment of spine disease is, you know, physiotherapy and surgery. And then it changed, and, you know, it became minimally invasive, and pain management came along, but it was haphazard. You know, the patient, you know, can go to physiotherapy or pain management or surgery, or sometimes patient from if physiotherapy failed to still go to surgery. And you know, hopefully recently that has changed, and it was recognized by, you know, neurosurgeons themselves on orthopedic that there is a very important role for minimally invasive spine intervention, radiology, and pain management. So this is the proper protocol, which is anybody who has pain should try physiotherapy, unless of course they have neurological deficit or significant neurological deficit, they go straight to surgery. But if they don't, if it's just pain, then they should try physiotherapy. If it failed, they try pain management or minimally invasive intervention, and if that failed, they go surgery. But we have to remember that even after surgery, you know, the neurosurgeons, they sometimes need to send patient back to physiotherapy, or sometimes they might need minimally invasive intervention or intervention radiologist to treat a residual pain post-surgery or a complication of surgery, or syndromes like failed back surgery, which is due to adhesions. The surgeons don't have any idea how to treat this, and they depend on the intervention radiologist to help them. Okay, so we all know this is the self-explanatory. The surgery is not without any problem. There's a lot of complications associated with surgery, either whether it's general due to like mortality or local due to nerve injury, and most common one is failed back surgery due to adhesions. Okay, now, unfortunately, still to this day, especially in the private sector, there are a lot of surgeries done unnecessary for patients. So, patients who have pain, significant pain, without any neurological deficit, there are still surgeries done. This is completely wrong. This is surgery should be done only for patients with neurological deficit. Grade 1 or grade 2, 1 or 2 spondylolisthesis are not actually indicated for surgery. A lot of surgeons still do fusion for grade 1 or 2 spondylolisthesis unnecessary. Degenerative disc disease, you know, surgery is done with fusion, sometimes small disc protrusion if somebody complaining with pain. Now, unfortunately, some of the surgeons, when the patient has significant pain, even though the disc is small, they don't give the patient the time for self-recovery, or at least refer them for physiotherapy or minimally invasive. So basically, you know, for all these, you know, previous conditions and any condition that doesn't have a significant neurological deficit, physiotherapy should be treated first. If not, pain management or even just injections, you know, steroid injections, and then you still have also minimally invasive intervention radiology procedures before you go to surgery. Okay. Now, what is the value? This is a comprehension of all minimally invasive methods done from all literature, you know, from systemic reviews. You know, it's between 60% to 100%. So basically, the average is 70% success rate using minimally invasive. What does that mean? I mean, 70% a big number or a small number? To me, it means that we will actually save 7 patients from going to surgery by doing minimally invasive. Even if it was, that number was 50%, I still would be happy that I can stop 5 patients out of 10 from going into surgery, which is, we know that it's not without this complication, either immediate or delayed. There is a recent study, a Scandinavian study, that looked at patients who had fusion, all different types of fusion for different reasons, and they followed them up for 5 years and 10 years. And after 5 years, there was 70% of the patient had significant disc disease, either the same disc or adjacent disc, or had failed back surgery. At 10 years, all patients have failed surgery. So, you know, the term surgery without complication, either early or late, is very difficult for somebody to, you know, defend. Now, as we said, that you have to be a clinician and treat and examine the patient, take good history. As a radiologist, you can review the images and correlate them with the clinical history. You have to explain to the patient the benefits of minimally invasive and the risk and the success rate and the failure rate, and most importantly, get informed consent. Now, the lecture says that there are basic and there's advanced minimally invasive procedures and interventional. Basics are, you're talking about injection, epidural facet injection, lumbar nerve root injection, radiofrequency ablation, pulse radiofrequency, sacroiliac joint blocks, piriformis injection, or tricuspid percent injection. These are simple injections that can be done as an outpatient procedure without even admitting the patient. Now we're just going to see just a few of these, you know. Sorry, after injection, then the more advanced things and minimally invasive is different types of percutaneous disc decompression. How to reduce the size of disc percutaneously. There are, you know, different methods. There's nucleoplasty, disc fix, there is intradiscal ozone, automated percutaneous disc decompression, disc laser decompression, and a system called hydrocision with the Benson water jet. All these are methods can be used for reducing. Other thing, tools that we have as a minimally invasive interventionist, okay, is videography or epiduralysis. MILD stands for minimally invasive lumbar decompression. Clodicare is a new system invented in Korea, and specifically for percutaneous foraminoplasty. We can use temporary spinal cord stimulation, and you know, Dr. Khamis talked earlier about kyphoplasty and vertebroplasty. Now, these are just different. We're just going to go through quickly through the images. When epidural injections, you have to insert. There's 3 different types. There is intralaminar, the first one on the left, and then the one in the middle is transforaminal, and the last one is caudal injections. Okay, facet injections is just under X-ray guidance. You identify the facet under oblique view, and then you can inject just steroids within the lower third of the facet joint. Lumbar nerve root block, again, as you can see in the images, it's a needle, and you put it underneath an oblique region, underneath the pedicle, and you inject contrast. You can demonstrate the sheath of the needle, sheath of the nerve, and you can inject steroids within the sheath of the nerve, either as a therapeutic or as a diagnostic method to identify the level of disease and the nerve affected. Now, similar to the lumbar nerve root block, you can use, instead of normal needle, you can use a pulse radiofrequency needle, and in addition of injecting steroids, you can do a pulse radiofrequency, which does a neuromodulation for that nerve root and helps adjust the signal or the pain signal in the nerve. Now, when we talk of facet radiofrequency ablation, it's a very, very important tool. Everybody must have a radiofrequency ablation machine from whatever type. You can use it most of the time when you're treating with a disc or any other pathology. You always combine it with I don't believe there's anything that's called facet syndrome by itself. Facet syndrome, whether radiological or not, is a clinical diagnosis, and it's usually associated with an underlying pathology like canal stenosis or a disc disease. So if you're trying to treat a disc disease, or canal stenosis, you might have to combine it with facet radiofrequency ablation, which basically either use heat, and that's the number one here, intra-articular radiofrequency ablation. You put the needle, as you can see in the first image on the left, within the facet and apply heat at 80 degrees for 1.5 minutes, or you can inject the medial nerve branch that supplies the facet, but in this way you have to take both branches, the superior and the inferior, because each facet is supplied by both branches, and apply a pulse frequency, and it's called the medial branch block, for 4 minutes. You can apply the same method either by injection or heat, and you can see it under plain film or under CT scan, and inject steroids, or you can use the same machine and apply heat within the sacroiliac joint for treatment of sacroiliitis. Now, we talked about percutaneous decompression. The simplest rule is ozone. A lot of people don't know about what ozone is. Just basically O2. When you go through a machine, it changes to O3, and that it has a lot of properties. It's anti-infective. It is breaks the cycle of pain. It's also remove inflammation from inside the disc and outside the disc, and it has kind of corrosive. A certain concentration can be corrosive and can reduce the central part of the nucleus and shrink. So we reserve it for either small disc or for degenerative disc. We use ozone. We also use ozone after we use any method, minimally invasive method, as an kind of antiseptic. My rate of discitis before I used to use ozone was perhaps 1 in 200 patients. After using ozone, the rate has dropped to 1 in 1,000, which is quite acceptable rate. Now, I'm going to talk about nucleoplasty. There is a reason why I'm talking about nucleoplasty. Is basically it's using cool plasma field to evaporate part of the nucleus, to shrink part of the nucleus, in order to help the disc protrusion to go back to the way it was. That's only used. It has, of course, an indication and limited indication. It's for contained disc. It's disc that it's not reduced by height more than 50%, and it's not occupying more than 1/3 of the canal. This type of indications for contained disc nucleoplasty is very good as a treatment for percutaneous decompression. Now, the next system is the disc fix. And now I like this fix for a bigger disc because it combines different things. It combines debulking. It has through a cannula you can put an actual tool, and the surgeons like this because you can remove a lot of material and see the material. You can use coagulation to evaporate some of the nucleus from inside, and you also can apply coagulation heat, and that's very good if somebody has a fissure or high intensity zone in the annulus. You can burn that as you come. So I like this fix. Now, in my practice, after trying all these methods, we try to just only use nucleoplasty for small disc, and for larger disc we use this fix because of the combination of plasma heat, debulking, and mechanical removal. Now, videography or videolysis. Now, a lot of people actually underestimate the value of just a videography by itself. Now, for cases, for things like when you have multiple disc disease, or for sometimes when the MRI doesn't show significant pathology consistent with the patient's symptoms, or for patients, specifically for patients post-surgery who have failed back surgery. Now, the MRI in all patients who have failed back surgery, if they don't have an adhesion disc, the area of surgery, it looks normal. It looks wide open, and there is the fusion, and it looks normal. There is no way to assess if there is adhesion. You need a videography, and you can see in this image here, there is a cutoff at level L5, and this image here at the level of L4, L5. Again, there's a cutoff of contrast. That's the disease of significant adhesion, whether it's because of the disc disease or because of previous surgery. And then you can use this catheter or any type similar to this catheter, which is called an epidurolysis catheter. And you can, under imaging, you can insert it through sacroiliitis and go inside to the area of adhesion and remove it under vision. And once you finish, you can re-inject contrast, and you can see how good you've done, how much you have removed. When you're happy with the result, it's a feeling, it's an imaging and result. And when you finish, you can inject steroids there as well to treat the area of the pathology. If there is a specific on a specific nerve, you can adjust the urologic catheter to that nerve and inject steroids. Okay, we talked about earlier, Dr. Khamis talked about the kyphoplasty and vertebroplasty. The one thing that I wanted to say now is that I think I heard Dr. Khamis using vertebroplasty. There was a reason for people using vertebroplasty, was basically economical. The only reason was economical, because if you know the advantages of kyphoplasty for treatment for vertebral compression fracture, or for you can still use it for cases like multiple myeloma or tumors, if there is no, the tumor doesn't extend to the spinal canal, is that the cost. The first kyphoplasty kit used to cost $3,000. It was monopolized and patented by Calphon. Now we can get a kyphoplasty kit for $400. And the other thing is that now, instead of bilateral approach, you can use unilateral approach, and there's new innovation in kyphoplasty. You can use a unilateral with curved balloon. Makes it easy. It's a 10-minute per vertebra, and in my opinion now, if I use vertebroplasty, which has a 40% higher rate of leak than kyphoplasty, and if a significant leak happens, you know, I would not be able medically to defend myself of not using a kyphoplasty, which is cost an extra $400. To always use kyphoplasty rather than vertebroplasty. Okay, mild minimally invasive lumbar decompression. This was invented by actually an anesthetist. He basically was just introducing of a cannula into the interlaminar space, and then with a similar device, a smaller device similar to the surgeon device that you can bite into the bone and into the ligamentum flavum and remove that, and you can see through these images the method before there is, you know, like a depression due to ligamentum hypertrophy, and we use under imaging with injection of contrast, and then the final results after removing the ligamentum flavum, that you can see that's a normal videograph. Now, this is the latest. This comes from Korea. This is a minimally invasive foraminoplasty system. We heard the lecture about the grading for foraminal stenosis. Until this was, came along, and you can see these are two typical images here of the kind of stenosis, the foraminal stenosis that can be treated by this method. It's basically a small cannula you insert, and then there is a little motor and teeth that once you connect them to the battery, you can just shave that part of ligamentum flavum that's causing stenosis. This is only for foraminal stenosis that's due to ligamentum hypertrophy, and we listened about it has, I've been using it now for more than 2 years. It's really significant, but it really depends on selection. You really have to select the patient. You cannot use it for, like we heard about grade D or even grade C. It's only for mild to moderate. All these methods we talked about are actually for, you can only use them for mild to moderate. Don't attempt to push yourself. Intraspinal spaces, this is something now is percutaneous, can be done by radiologists. It treats central canal stenosis. This has gone out of fashion because most of the patients who have canal stenosis are elderly and have osteoporosis, and usually with putting a device, a hard device, it causes recession after a while. The last thing I want to talk about is there is a device now, which called centric pulse. It's basically you can introduce this for this patient who has fusion, and post-fusion has adhesion, which gave the patient symptoms of bilateral sciatica and bilateral leg pain. It's basically severe adhesion. We couldn't open it with epidural lysis, so the only option left is to actually apply stimulation at the level of the cord or above the area of adhesion in order to reduce the pain. So in conclusion, back pain is a major problem. It requires countless emergency room visits, a significant physical and emotional cost. Intervention radiology or image-guided spine procedures can diagnose and relieve and treat a lot of back pain and mild to moderate spine problems. Many patients also, have a significant quality of life, as we said, up to 70% of patients treated this way. Thank you very much.
Thank you, Dr. Tariq, and very comprehensive and excellent talk on various interventional spinal procedures. Before we have conversations, a few questions are invited from the audience. Any questions from the audience, please? Okay. If no questions, we'll adjourn the session. And
Everybody now understands.
yeah, excellent. Thank you. And so we'll move on to the next session, please.
What do you neonatal spine. Just my is DPT also. This one. So I know keep on looking. Which one? This is the file. It has to be the ones that okay. The links. Yeah. Let's see this. Search. Yes. Yes. Thank you. Yeah, why not?
बैटरी खत्म हुआ भाई हाँ जी
अच्छा फिर लैपटॉप उठाना पड़ेगा इधर आओ मेरा मोबाइल
Questo te lo dai, i costi ne valgono, tu dai.
रिपीट ब्रेक बंद हो जाएगा चाहे जो बिस्किट हो ना बिस्किट जूस है खाना खाओ थोड़ा फ्रेश रहो एक्टिव
It is the almost possible consequences.
सही बात है, 1 ग्राम का जूस है 2 ग्राम में पिएगा। ये उधर मिलता है जूस? ये हाँ दुकान में मिलता है।
मैं भी नहीं पी जाएगी जूस।
तुम खाओ। ये खाओ, ये खाओ। ये कोई सी
कौन सी आना से ये मैं कलर वाला खाएगा।
बहुत टेस्टी। थोड़ा मुझे दो।
Good afternoon, everybody. We are going to start our last session in this afternoon. Dr. Barafa and me will be moderating this session. The first speaker for this session is Dr. Sopini Wan. She's going to talk about infection of the spine. So, Dr. Sopini.
Thank you, Dr. Mohammed, for your introduction, and I would like to thank the committee for having me here. I have nothing to declare. For my talk today, I will start with general consideration of spine infection, followed by routes of infection, age-related changes, and imaging findings in the terms of principal findings, the differences between pathogenic and tuberculous spondylitis. And I have one slide of announcement at the end. Start with the general consideration. With increasing imaging techniques, the frequency of spondylitis and discitis appears to be 2 to 4% of osteomyelitis, and the ratio of male to female is 3 to 1. All age groups are affected, usually in the 5th and 6th decades. The site of involvement in order of frequency is lumbar, thoracic, sacral, and cervical spine. In patients with back pain, we should think about pathogenic spondylitis when the patient has pelvic infection, undergone surgical procedures, or patient in debilitated conditions, And the most frequent pathogenic cause is Staph aureus, which is here, followed by Streptococcus and Pneumococcus. The cause may be gram-negative bacteria or other agents, such as Mycobacterium species, particularly tuberculosis, which is right here, the fungi or parasites. I don't want to say rarely, because in endemic areas such as my country, Thailand, TB is not rare. Routes of infection. Organisms can reach the vertebra by first hematogenous spreading, which is the most common route, via the arterial and venous systems. Second, spreading from nearby source of infection, such as the psoas abscess. Third, direct implantation. And fourth, post-operative infection. The prevalence is 1% after simple discectomy, 6 to 8% after attempt fusion with hardware. As you can see in this case, infection of this and vertebral body may occur at non-surgical level, that I will explain later. Distribution of arteries in the spine is similar in different levels, and the general arterial pattern can be found from T2 to L5, which consists of the segmental artery that providing branches to feed the vertebral body, spinal canal, and the posterior element. And this is the segmental artery in MR imaging. Venous system of the spine is tree-like or Y-shaped in configuration and draining into the central dorsal nutrient foramen, which is here in diagram and here in CT scan, and then draining into the valvulus extensive epidurovenous plexus, which is here surrounding the spinal canal. This is in the diagram and this is in the MR imaging. And this plexus runs along the spinal canal in connection with the Batson plexus inferiorly, and this is the valvulus system. So the flow and drainage directions are according to intra-abdominal and intrathoracic pressures, and therefore infection can spread proximally and distally. And this is why post-operative infection can occur in non-surgical levels. Move on to age-related changes. Below 4 years old, end arteries perforate the end plate and entering the disc, providing arterial supply. So this group of patients can develop discitis originally. As you can see on the right, infection starts in the disc. At old age, there is this degeneration with ingrowth of the fibrobascular tissue in the same manner. So old age group can develop discitis originally as well. And how about adult? In adult, the richest ramification is at the subchondral region, and therefore this is the most common site of initial infection. This patient came with back pain, and we can see vertebra plana right here. The disc above and below are completely normal. It doesn't look like infection at the beginning, and metastasis was the first consideration. Biopsy was performed and came out to be tuberculosis. So this case confirmed that infection starts within the vertebral body, and normal disc cannot rule out infection. Imaging findings. When organism implant within the subchondral area, the patient may have symptoms, but radiograph is still normal. This patient has back pain and fever for 4 days. Radiograph doesn't show anything. MR imaging on the same day, you can see fluid within the disc and anterior epidural soft tissue component. After 2 to 4 weeks after implantation, infection grows by destroying the end plate, involving the disc, and cause decreased disc height. Then we can detect on radiograph. In this patient, you can see the space narrowing right here with permeative destruction of the vertebral body with decreased height. MR imaging on the same day confirmed discitis and decreased height of the bone. If the patient left untreated or treated incorrectly, infection will progress in 2 ways. The first way is crossing the disc and involve the adjacent vertebral body. You can see bone destruction here, obliteration of the disc space, and involvement of the upper level. And MR imaging confirmed the radiographic finding. The second way is to extend under the anterior longitudinal ligament which was called subligamentous spreading, which you can see here as well. The diagnostic values of MR imaging for spine infection. Sensitivity is 96%, specific 92%, and accuracy is 94%. The affected area shows decreased signal on T1, increased signal on T2, and enhancement after contrast injection. And there is a question, what is benefit of contrast injection for spine infection? And the answer is, it helps improve visualization of extension. As in this patient, you can see soft tissue extension more clearly compared to T2, both at the epidural location and subligamentous location. MRI findings for good to excellent sensitivity of spine infection consist of the paraspinal and epidural inflammation. Right here, sensitivity 97%, this enhancement 95%, increase the signal on T2 93%, erosion or destruction of at least one end plate 84%. You can observe that the bone destruction is less sensitive than soft tissue findings. And this is the differences between TB and pathogenic spondylitis. The sign that suggests TB consists of well-defined paraspinal signal, smooth abscess wall, paraspinal or intraosseous abscess, thoracic spine involvement, multiple bodies involvement, subligamentous spreading more than 3 levels, and for pathogenic infection, ill-defined paraspinal signal, subligamentous spreading less than 3 vertebral levels, and abnormal signal around the facet joint. In this case, you can see well-defined paraspinal signal, thin wall abscess, intraosseous abscess, and normal finding around the facet joint. In sagittal plane, you can see multiple bodies involvement causing gibbous deformity and long segment of subligamentous spreading. No doubt that this is tuberculosis. How about this patient? Ill-defined paraspinal signal. Involvement of the muscle around the facet joint, which can be seen in axial and sagittal scan, and subligamentous spreading for 2 levels. This is pathogenic infection caused by Staph aureus, and you can compare between the 2 diseases. We conduct a research project to study whether subligamentous spreading can help diagnose spinal TB compared to spinal metastasis, and we found that TB shows significant more prevalence of this finding. 78% of TB and 40% of metastasis show subligamentous spreading with statistical significance. We also measure the thickness by drawing a line along the anterior cortex of the vertebral body, and the red line, which is the thickness, perpendicular to the yellow line, and we found that each millimeter of increased maximum thickness of the subligamentous spreading right here increased the probability of spinal TB about 1.36 times. Moving on to diffusion-weighted imaging. It is a tool for differential diagnosis of certain spinal diseases, which regarding to the changes of motion of the water molecules. The results so far not quite promising, particularly in the vertebral body. We conduct another research project to study the ADC value, which is the apparent diffusion coefficient, using 3 Tesla MR machine, because majority of the published articles using 1.5 Tesla machine. We compare between infection and malignant tumor of the spine, and we found a cut point of 1.116. If the mean ADC value is higher than the cut point, there is possibility to be infection with diagnostic values as appear in the table, and accuracy is about 72%, not much different from literature. Let me show you a case. This patient has subcondylarthration right here and show enhancement after contrast injection. It looks like infection, but the mean ADC value here is 1.093, which is below the cut point, suggesting that the cause is non-infective. This is metastatic lung cancer. ADC doesn't help in all cases, but in some cases it does. Moving on to the PET and MR imaging. FDG PET has higher diagnostic value to detect early spondylodiscitis after the start of clinical symptoms. Both techniques, PET and MR, had similar diagnostic value after 2 weeks. This is to talk about the MIS, minimally invasive surgery, which is increasingly performed and shows significant reduction of surgical site infection. If we concern overall type of infection, MIS decreased infection by 7-fold. With decompression alone, 10-fold reduction, and with decompression and fusion, 4-fold reduction. Although infection decreased, we still see some cases. This patient has this herniation status post-decompression with a very small incision. He developed fever and recurrent back pain. In this patient, in sagittal plane, we can see soft tissue lesion right here, show enhancement after contrast injection. In Agssr scan, you can see hypointense lesion with peripheral enhancement. Open surgery was performed and found that this is retained this fragment with infection. This is because the incision is very small and surgery was performed through a scope with limited FOV. And this is my announcement. We are organizing Don Resnick's course in Bangkok, Thailand on November 8 to 10 this year. And November 11 is Loi Krathong Festival. Registration will open in this March or April at this website, which is the website of the Royal College of Radiologists of Thailand. We are trying to make the registration fee as low as possible. Even Don Resnick said it may be the cheapest ever. Thank you very much for your attention.
Thank you, Dr. Sopanwan, for your lecture. Our next lecture will be presented by Dr. Nirmala Vijay Sinha from Sri Lanka. And it will be about TB spine.
I must thank the organizers for inviting me here to give this lecture. And my talk today is on tuberculosis of spine, and I think some of the information overlaps the previous speaker. CNS TB, it's a granulomatous infection caused by Mycobacterium tuberculosis, and it is heterogeneously spread from a primary focus, usually in the lungs. It's leading cause of mortality and morbidity in the developing world, and 1/6 of the 3 million of the global mortality is due to TB. Now, the chest radiograph is abnormal only in about 45 to 60% of patients. As you can see, this is the typical chest radiograph of a patient of extensive pulmonary tuberculosis. These are the new estimated TB cases in the world. This shows the number of deaths due to TB, and it involves countries like North America and Latin America as well, Australia and New Zealand. Then this is the global incidence of tuberculosis in 2010. Now, the incidence of tuberculosis is the estimated number of new pulmonary, smear-positive and extrapulmonary tuberculosis cases, and the incidence includes patients with HIV. The number of estimated cases in 2011, new cases, was 14,000. Now, spinal tuberculosis is a destructive form of tuberculosis. Half of all of MSK is TB, most common in children and young adults. Genetic susceptibility to TB has been demonstrated. Characteristically, as mentioned earlier in her lecture, there is destruction of the intervertebral disc and the adjacent vertebral bodies with collapse of the spinal elements, anterior wedging, which leads to kyphosis and gibbous deformity. And the thoracic and the lumbar region are the most frequently affected. It forms cold abscesses, And earlier they thought that it was non-contiguous involvement of the vertebral bodies is more common than was previously thought. Now the histopathological diagnosis is the gold standard, where you do a biopsy from the center of the vertebral body. The common clinical manifestations are constitutional symptoms, back pain, spinal tenderness, paraplegia, and spinal deformities. Now normally part spine presents really with back pain, and you can have rapid or slow loss of motor and sensory function at any level, and they can have cord compression. Then there can be previous systemic diseases, and there can be, as mentioned earlier, kyphosis, Tipper's deformity, and scoliosis. Normally you don't see pulmonary TB as mentioned earlier in up to 50% of cases. Now the plain X-rays, the infection is subligamentous and it is beneath the anterior longitudinal ligament, and it spares the posterior elements, multiple levels, mild reduction of the vertebral height, and actually the thing that you have to normally see in the plain X-ray is the irregularity of the anterior superior end plates, which is difficult to see sometimes and which is shown better on MRI. Then preservation of discs are there in the early stages, collections of cold abscesses with reossification. You can have ivory vertebrae. Now this shows here the irregularity of the anterior superior end plate and reduction of the disc height that you can see in the plain X-rays. The use of the CT scan, it can show you the paraspinal soft tissue masses, lymph involvement, lymph node involvement, extent of other organs, and the integrity of the vertebral column. MRI is the imaging modality of choice, and epidural abscesses, cold abscesses, extent of bone marrow involvement, paraspinal and subligamentous disease can be seen. Now this is a typical gibbous deformity or the spot spine which we don't see normally now. Now certain things that are specific for TB was mentioned earlier. Sometimes it's difficult to differentiate TB from metastasis, and in metastasis both show diffusion restriction, and the pedicle is involved more commonly in malignancy. Now this is a case of a 25-year-old patient who presented with back pain and tingling sensation in the fingers and feet. There is involvement of the thoracic vertebral body, and you can see here the anterior superior, the end plates are involved, and in this patient the chest X-ray was normal and there was thoracic cord compression. The next patient is a 45-year-old patient with backache of 2 years duration, and you can see the L4, L5 disc involvement. There is compression of the lumbar nerve roots and you can see the disc is completely involved here. The chest X-ray was negative in this patient. This is a 27-year-old male patient from the Foot Club, that is up north district in Colombo. He was a student studying in England. Now he had this neck pain and he had gone to England into the NHS, and they had given him some analgesic treatment, and this was the X-ray that was taken. And they said that the X-ray was normal and sent the child home. After several months, I think 3 months, the child developed tingling sensation in the fingers and the hands. The father is a principal of a school and the mother is a school teacher. Being intelligent patients, whatever they have told the child, look, if your pain is not getting better and if you are gradually having this odd feeling in your fingers and hands, please come back to Sri Lanka. Now in this X-ray, which they said was normal, you can see there is widening of the prevertebral soft tissue space which was missed. This patient came and was sent for an MRI, and this is the MRI findings where you can get these cold abscesses all over, and you know, his neck he had scoliosis at that time. These are the cold abscesses right around the neck, and ultrasonically I did an ultrasound scan, and this was the picture that I saw. Multiple cold abscesses, and I did an FNAC, I don't have the picture now. Milk colored pus was aspirated, and that was positive for staining of TB. These are the same patient. These are the CT scans where you can see the vertebral bodies have been eroded by the disease. This was another 44-year-old male patient who presented with fever and neck stiffness, and you can see involvement here with at C6, C7 displayed, and there is mild cord compression. In this patient, the chest X-ray was normal, the PCR and the MANTU was positive. There is another 29-year-old female patient who came with backache. There is L4, L5 displays, and there is subligamental spread, and there is small epidural component, and you can also see a psoas abscess. Not only a psoas abscess, you can see an abscess in the soft tissues. These are the typical psoas abscesses that you can get in tuberculosis. This is a patient that came with chronic backache. And here you can see that the L4, L5 disc space is narrowed, and with after contrast there is enhancement. This vertebral body shows a lot of soft tissue enhancement with paraspinal spread. This patient is the same patient. The chest X-ray was normal, and the only thing that was ESR was normal. The only thing that was abnormal was the PCR. In this patient, I like to show you this one is like. Okay, in this patient, I took this slide to show you the involvement of the pedicle in metastasis. Okay, this is a 50-year-old patient with a history of hepatic cell HCC who has been chemo-embolized 1 year ago, and I think it is not very clear, but the embolization, the HCC was in this area. He presented with shortness of breath, and the CT chest and abdomen was performed, and he had a pleural effusion. And in the pleural effusion, the aspirate didn't show any malignant cells, and there was this destructive vertebral body, and they really thought that this was due to metastasis. But because he was complaining of a backache, they did an MRI, and the MRI showed this abnormal vertebral body at T11 level with a paraspinal soft tissue component, and there was involvement of the vertebral bodies at L4, L3, L4 and L5, and there were cold abscesses. As you can see, there was enhancement of the soft tissues of the back, and there is a left-sided paraspinal soft tissue mass. So really, though we thought it was metastasis, this was really TB, this patient with HCC. This is another 25-year-old male patient who complained of backache for 6 months, and you can see L4, L5 displays here, and this patient was treated for TB, and his PCR was positive. This is the same patient, the sequences, this is the post-contrast imaging. Then, same patient has a left-sided soft tissue mass, cold abscesses, and destruction of the vertebral bodies. And thank you very much. This is just a short presentation of some of the images that I have collected on TB.
Thank you very much, Dr. Nirmila, for this comprehensive talk. Now we're going to move to a third talk. It's for Dr. Praveen Tin. He's going to talk about the neonatal spine ultrasound approach and current concepts.
Yeah, very good afternoon. Before I start, I would like to thank the AMS for giving me this opportunity, and at the same time congratulate Dr. Khalid Ali Ismail and his team for organizing such a wonderful conference. Today I'll be talking to you about neonatal spine and the role of ultrasound and current concepts in evaluating neonatal spinal abnormalities. As the progression of the fetal ultrasound has become more and more in utilizing that to evaluate the spinal lesions in the fetus, the incidence of neonatal spinal abnormalities have come down dramatically. There are two things that are responsible for it. That is, one, that we have started diagnosing these neural abnormality right in the fetal stage. That is one, and quite often they are diagnosed very early, even at about 13 to 16 weeks of gestation, and quite often the parents opt for termination. The second important factor is that the utilization of folic acid. As the folic acid has been utilized pre-conception, conception and post-conception, the incidence of neural tube abnormalities or neural tube defects have come down dramatically. So these are the two things which are responsible for decrease in the neonatal spinal abnormalities. But then still we do come across certain abnormalities in the spine, particularly in the form of various closed and open neural tube defects. As we all know and understand that MRI is the gold standard in evaluating the neural tube defects, particularly in the neonatal period, but then it is quite often limited to evaluating the open neural tube defects. The reason being that the open neural tube defects are the ones where there is leaking CSF, and the possibility of using ultrasound gel results in infections. That is the reason why we don't do that. At the same time, particularly when we are doing evaluation of the post-surgical spinal abnormalities, in that situation also, because of partly open lesions, it is risky to use that one because we may introduce infections. Now with this concept, now we have started utilizing ultrasound. And this ultrasound particularly is very useful as a preferred standalone tool. It's extremely useful in certain specific cases, particularly when it comes to congenital spinal dysraphisms and in acquired spinal cord abnormalities. Now, when do we do this one? We usually do it in the first 3 months of the neonatal period. The reason is that this is the time when the paired posterior arches, that is the spinal arches, are not ossified. At the same time, they are predominantly cartilaginous. As being cartilaginous, it allows the ultrasound to pass through, so it acts as an acoustic window. So that is the reason why we start using ultrasound in evaluating these lesions, particularly in the first 3 months period. Now, ultrasound, as we know, there is a huge list which tells us that it is more useful than MRI. But most important thing is there are 3 components which are extremely important. Is that it has no ionizing radiation, there is no sedation required. At the same time, there are no movement artifacts. And most important thing is, as we can do a dynamic assessment of the card pulsations, it gives us a lot of information as far as evaluating the tethered card. So that is the reason why we need to use the ultrasound in evaluating these lesions. Now, coming to the clinical implications. Now, as I said, quite often we prefer to do in a closed neural tube abnormalities. In that situation, there are certain clinical presentations that we come across and which are sent to us for evaluating, because most of these lesions which are not picked up in the antenatal period, so these are typically present with what you call it as an atypical sacral dimple, palpable subcutaneous mass, sacral mass, and cutaneous stigmata such as the hair tuft, stincap, hemangiomas, as well as the sinus tract and the skin pigmentations. These are the commonest clinical presentations that we come across while they are being referred to us. Not only that, in situations like in some of the cases where you diagnose a neural tube defect late in the pregnancy, during the pregnancy, where they are associated with the cloacal exstrophy as well as anorectal atresias, or in a caudal regression syndrome where there is an absence of agenesis of the sacrum, these are the lesions again which are sent for neonatal evaluation. Whenever there is a suspected intraventricular hemorrhage, in order to know whether there is any hemorrhage in the CSF of the spine, we definitely do an ultrasound examination in evaluating them. And then whenever there is a difficult lumbar puncture, and not only that, the anesthesia can also be given under the ultrasound guidance. At the same time, post-injury and trauma sequelae can assessed or evaluated by using ultrasound. Now, coming to the post-surgical, particularly the follow-up of these complications in the sense that we can evaluate the presence or absence of the retethering of the card. So these are the things where we can use ultrasound in evaluating the neonatal spine. Now coming to the limitations, as I said, the most important limitation being the open neural tube defect, where there is a leak of the CSF which can cause the infection. So that is the reason why in that situation, if it is unavoidable, we try to use what is called as the sterile gel, or you can use even the betadine gel, which we normally use in our patients, which can avoid introducing infection in these situations. Now coming to the equipment which we use, most important thing, the possibility of evaluating the neonatal spine basically is because of the high frequency transducers that are developed. The transducers which we now use are almost about 7 to 17 megahertz, which gives us a great resolution. Not only that, what we use is what is called as a long footprint, because you need to cover, or the region of it, a large region of interest can be covered by using a large footprint. Now we have what is called as the panoramic view, or an extended field of view, where you can move your transducer, stitch the image in such a way that you can trace the spine right from the cranial region to the caudal aspect, so that you can get an entirely delineated spine. At the same time, we use certain small footprints, particularly when we want to evaluate the fistulous tracts from the out for the needle guidance, or doing a lumbar puncture, or doing an anesthesia. So these are the applications, or the technical aspects of, or the equipment that we can try to use. Now, another important aspect of the evaluation of neonatal spine is the patient's position. That is extremely important, because what we try to do is we always have the fetus or the neonate in a prone position. At the same time, we get the head up, so that the CSF gets collected in the lower aspects. That is where we would like to evaluate the lesion, or wherever the lesion has to be evaluated, we try to get pull the CSF into that region, so that we can get a good contrast. At the same time, there are certain instances where we can even position the neonate in a decubitus fetus position. And not only that, we try to put a rolled towel below the abdomen of the baby in order to widen the posterior arches, so that you can use the opening or the window as an acoustic window. Then we use the UCG ultrasound guided spinal taps. Whenever we want to do an ultrasound guided spinal tap, what we try to do is we put the patient in such a way that the caudal region becomes dependent, so the CSF gets collected there. You can see more amount of fluid. At the same time, it becomes easier for us to do the tap. At the same time, whenever we have a distressed neonate, this is one of the situations where we would like to make use of the parents or the mother in order to take her around the lap, so that you can make the baby lie down on the lap of the shoulder of the mother and try to evaluate the neonate. This is the typical examinations which we do. We keep the neonate in a prone position and use a large footprint. At the same time, sometimes we even put them into the decubitus position, depending on the lesion which we are trying to evaluate. Now coming to the sections which we take, normally we take the axial as well as the sagittal sections. The axial section is particularly useful for, is taken from the caudal region to the cranial region. Sagittal sections is mid-sagittal or para-median sagittal, or the two sections that we try to take. Now once that is done, what are the things which we look for as far as the axial and the parasagittal regions, are sagittal and parasagittal sweeps are concerned, or we particularly in the axial spleen, we look for the post now. So these are the factors which we have to keep in mind while evaluating these fetuses. Now dynamic evaluation has come into practice in such a way that we can make use of this dynamic. As you can see, you can continuously take an extended field of view and you can see the whole of the card. Not only that, you can tilt it to the axial view, and as you can see the pulsations here very nicely demonstrated. So this sort of a dynamic evaluation of the card can rule out the possibility of a tethered card, which is an extremely important, one of the most important factors which we need to evaluate as far as the evaluation of the neonatal spine is concerned. Now, in the sagittal and the parasagittal scans, the most important thing is to identify the conus. How are we going to identify the conus? The normal conus, as we all know, is usually at about the lower end of the L2. But in certain cases, like in certain situations, it may be at L3 in term babies at the upper part of the L3, or at the lower part of the L3 in preterm babies. And how are we going to evaluate? We are going to evaluate by taking an axial section right from the coronal region to caudal region, or you can get the 12th rib and gradually come down to T12. which identifies as T12 and gradually come down, or you try to identify L5 and go up in order to evaluate the conus. So these are the two things that we follow in identifying the conus. Not only that, sometimes we may take even the radiological help in evaluating these conus. Now, identifying the phylum terminal. Again, after the conus, the next important structure is the phylum terminal. It is nothing but a closely packed parallel lines extending from the conus. As you can see here, it extends right from the conus and downwards, and it usually measures about 2 millimeters, and it extends right up to the distal end of the thecal space. So this is how you identify the phylum terminal. The next important thing is that whenever we see we try to evaluate the cauda equina, which again is an important factor. This is nothing but the nerve roots comprising the cauda equina, which actually lie in the dependent part of the thecal sac. At the same time, you can find, as I said, you can find that there could be a mild oscillation, as you can see here, with the cardiac pulsations as well as the respiration of the neonate. So this is an important factor which we have to keep in mind. And then whenever you take an axial section, we can see that there is a symmetry, that the symmetry of the cauda equina on either side of the midline, so which is an extremely important factor in identifying normalcy and abnormalcy of the cauda equina. Now, coming to, it is always essential that we need to identify certain normal variants which can also be responsible or give a false impression about an abnormal spinal canal, particularly the one which is called as the filar cyst or the cyst in the phylum terminal, which is just seen caudal to the cauda equina, and then you can find that there is a hypoechoic fusiform shaped structure which is just below the cauda equina. We have to be cautious that it could be because of the filar cyst, but not an abnormality of the cauda equina. The other one is the central lucency. Sometimes this central canal could appear very, very large, and you should not be mistaken it as an abnormality or a hydrosalpinx. Okay. And then what we have is the pathologies which we try to evaluate by doing a neonatal spine is the congenital malformations like open, closed spinal dystrophism with or without soft tissue mass, and then the complex spinal dystrophisms. Acquired abnormalities like birth trauma, intraspinal extension of the neurogenic tumors, and meningitis. These are the things which we try to evaluate. And when it comes to the open, as I said, open is not very aggressively practiced unless it is really required, where the baby is not able to withhold in the MRI. So in that situation only we try to evaluate the open lesions. But whenever it is usually the closed lesions with this, which is usually with the skin cover, which could be because of the meningocele or the lipomeningocele or the lipomyelocele. So in this situation, when we have a closed, these are the various lesions that we try to evaluate. One is the closed meningocele or meningomyelocele, hydromyelia, syrinx, diastematomyelia, spinal lipoma, and dorsal spinal sinus, congenital caudal regression syndromes, tethered cord, and probably meningitis. So these are the conditions which I will try to show you. First and foremost thing is the meningocele and meningomyelocele. It's nothing but a herniation of the meninges. When if it is associated with the neural component, then you call it as a meningomyelocele. If it is not associated with it, you call it as only a meningocele. What we find on ultrasound is that there could be a saccular herniation without any internal echoes, which is a meningocele, with internal echoes or strands if it is a meningomyelocele. Suppose this is the classical example where you can see that there is a herniation of the meninges. You can find certain strands, echogenic strands, which is basically because of the meninges but not the neural component. Whereas here it is an extended field of view or extended view or the panoramic view, where you can see that the cord is being stretched downwards, pulled downwards. Not only that, there is a cystic area there. Along with it, there are certain strands which are associated with the neural component. So these are the things which can be easily demonstrated or differentiated between a meningocele and a meningomyelocele. The reason why we need to know them is that the prognostication depends on the identification of these neural components. So keeping that in mind, the other important factor which we come across is the hydromyelia or the syrinx. Hydromyelia, as you all know, that is nothing but dilatation of the central canal, which is filled with the CSF. And then the cortex is stretched out peripherally. So basically on ultrasound, what we find is that we find echogenic lines of the central canal of the spinal cord appearing separated, and the central canal appears widened. And in syringe, what happens is it's nothing but a fluid collection in the spinal cord other than the central canal. And it is very difficult to differentiate one from the other. Whereas here you can see a typical hydromyelia as well as the syringe, where you can see that the hypoechoic area stretched out, the canal is widened and the cortex is thinned out. So this is a typical appearance of this one. And we have the diastematomyelia, which is nothing but the splitting of the cord. Basically, it could be because of a cartilage, because of a osseous content or a fibrous tissue, which can divide the cord into two halves, which could be symmetrical or asymmetrical, and at the same time they can be side by side or anterior and posterior. As you can see here, this is the normal cord, whereas here you can see the split cord because of the echogenic spur, and you can see that there are two cords which are equal in size, which are set side by side. The other things are the spinal lipomas, which are very classically seen as a hyperechoic area, which is extending from the subcutaneous tissue into the neural canal, which is very typical of a lipomyelocele. Then we have what is called as the dorsal spinal sinus, where what we find is that basically we find a hypoechoic area, and this sinus appears as an anechoic elongated structure, and at the same time along with it we can find the extended superiorly from the skin surface into the spinal canal. It's very classically demonstrated by evaluating like this. Then comes the caudal regression syndrome, which is very, very rare. What we find basically is that there will be caudal regression syndrome associated with sacral agencies and a blunt distal cord. This is a classical blunt distal cord which we can see in caudal regression. The most important area where the neonatal spine evaluation by ultrasound is because of the tethered cord. Pathologically, it is nothing but the fixation of the cord in an abnormal caudal regression. That is one. Because of this fixation, the cord suffers the mechanical stretch, distortion and ischemia, and dynamic ultrasound is the most important thing. And normally, as we know, that it is at the lower level of the L2, but if it is placed at a higher level, as you can see, this is normal cord with a this is the normal cord, and we can see that here the cord is fixed because of the strands which are attached. Not only that, you can see that there is some amount of tethering of the cord which is being pulled downwards lower than the L2 level. So these are the typical examples where we can see that there is an abnormal position with abnormal collection of the CSF, which is very typical of a tethered cord. So keeping these things in mind, the dynamic evaluation of the spine in the neonatal period is the most important application as far as the ultrasound is concerned in the neonatal. And somehow nowadays we have started evaluating for meningitis, where we can find that the CSF is echogenic, at the same time it is trabeculated. So to conclude, the most important thing is USG is the primary modality in imaging, and it is a tool which is very much preferred in the neonatal period. With high resolution ultrasound, it is now with an extended field of view, it is now possible to evaluate the spinal lesions in a better way, and it is real time, so you can have the dynamic examination. The most important indication is the occult tethered cord, which is extremely important in the clinical scenario in counseling the parents. USG is also helpful in the evaluation of post-operative status of the spine, and sonographic visualization of the spine decreases with age and the size of the patient. So as the patient becomes bigger and bigger, it becomes difficult to evaluate. So the first 3 months are the ideal period where you try to use ultrasound in evaluating the ultrasound. Thank you very much.
Thank you very much, Dr. Praveen, for coming, and you will have 2 hours to catch your flight. Thank you very much. It was a very nice presentation. Our next speaker, Dr. Yobashi from Japan. He will talk about sports related neck and back.
Good afternoon, everyone. I am going to talk about these topics about spinal pain caused by sports. I classified spinal pain into 4 types: hyperextension, hyperflexion, direct trauma, and chronic ankle instability disease. The first topic, hyperextension. Do you know sufferer's neck? It's very common condition of sufferers. The first sufferer's neck is related with pattern and wipers. They usually keep hyperextension with their neck with paddling. Then C5 and C6 vertebrae hurt. The paddling posture gives a lot of pressure on the cervical muscles and nerves, so they feel pins and needles in the hand, arms, and triceps, back pain, and numbness. This is the other surface condition, surface myelopathy. It's also caused by hyperextension. Cytal T2-weighted image shows severe increased signal intensity in the central aspect of the cord. The cord medullaris is enlargement. Surface myelopathy was first described in 2004 by Thompson. The surface myelopathy is a rare, non-traumatic spinal cord injury that usually occurs in novice surfers. It commonly occurs on their first surfing lesson. The mean age of patients is 25 years and 80% is male. The cause of surface myelopathy is uncertain. Thompson said that causes might include avulsion of perforating vessels, vasospasm of the artery of adenocubitus, or transient ischemia secondary to reduced blood flow to the spinal cord due to mechanical pressures. Symptoms include back discomfort, variable motor sensory involvement, and urinary incontinence. Steroid pulse therapy is effective. This is also hyperextension spinal injury. This patient is a rhythmic gymnastics player. The MRI shows high signal intensity in the interspinatus ligament. Here. She has a no disc herniation or other lumbar abnormalities. Repetitive lumbar spinal movement in the sagittal plane precipitate injury to varicose posterior element. Strain of posterior soft tissue can lead to structural changes in the lumbar interspinatus ligaments. Rupture of the spinous spinatus and interspinatus ligament may occur. This is most common in women, aged between 15 and 35 years. Bullseye are also visualized in the same area. This patient is a cheerleading girl. Her MRI is also the same finding as the former patient. Her interspinatus ligaments show high signal intensity. In addition, her spinous process shows low signal intensity, suggestive of osteosclerosis. It's due to chronic contact between adjacent spinous processes. This case is a hyperflexion injury. This patient was swimming in the ocean and was caught by a big wave. He was violently rolled over in the sea. The MRI showed compression fracture and interspinatus ligament tear. This results from excessive flexion of the spine. Next case is a traumatic lesion. This patient has a severe back pain. The radiograph showed fine calcification close to spinatus process here. On CT, round-shaped calcification is visualized. Soft tissue swelling is also seen around the calcification. MRI shows high signal intensity, suggestive of bone marrow edema at the left pedicle of L5. Calcification is here, very close to the left pedicle of L5. Soft tissue swelling is very prominent with a high signal intensity. So I asked him about his traumatic history. Actually, this patient played nunchak. Do you know nunchak? Here is nunchak. Chinese movie star often play this nunchak. He played this nunchak and he hit his back with it. After that, he felt a severe back pain more and more. So it's consistent with myositis ossificans. Myositis ossificans is a benign process characterized by heterotopic ossification within large muscles. It typically presents as a painful, tender, enlarging mass, which in 80% cases is located in large muscles of the extremities. So this case is relatively rare. Myositis ossificans is caused by direct trauma to muscle. Young adults and adolescents are most likely to develop myositis ossificans. Calcification usually began to become apparent on brain radiograph and CT within 2 weeks, and the lesion reaches the classic well-circumscribed peripherally calcified appearance by 2 months. Over the following 4 or so months, they typically become smaller. Finally, I am going to talk about chronic ankle instability. Chronic ankle instability results from ankle sprain. Ankle sprain is caused by a plantar flexion and inversion of ankle. Then, anterior talofibular ligament and calcaneofibular ligament tear happen. Posterior talofibular ligament is less commonly involved. When the ankle sprain happens, early functional rehabilitation allows for the quickest return to physical activity. About 20% of patients with an acute ankle sprain develop chronic ankle instability. Also, the failure of functional rehabilitation after the acute ankle sprain leads to the development of chronic ankle instability. CAI is often associated with sinus palsy syndrome, osteochondral defect, peroneal tendinopathy, subluxation, subtalar instability, and so on. For athletes, recovery of dorsiflexion of the ankle sprain is the most important thing. Lack of dorsiflexion range is increased risk of re-injury and limitation of activities. The dorsiflexion lunge test is a weight-bearing test performed by placing the foot perpendicular to the wall and lunging the knee towards the wall. And about this. The foot is sequentially moved further away from the wall until the maximum range of dorsiflexion is achieved. The heel should not be lifted off from the floor and the subtalar joint should be locked. Less than 10 cm distance from the foot to the wall is thought to be at risk. Also, angle of tibial shaft in reference to the wall is measured. This one. Less than 35 degrees is restricted. This test is predictive of future injury. Lack of the dorsiflexion range may be mainly comes from 2 pathologies. Lack of the dorsiflexion range has proved to lead to the low back pain through secondary lordosis and ACL injury through so-called back posture. So increased lordosis is associated with lumbar pain and associated with herniation and spondylosis. And back posture is ACL injury. So CAI is associated with not only ankle pain but also low back pain and knee injuries. Here is the conclusion. We have to know increased lordosis of spine gives pain. Also, we are very careful for CAI when we get an ankle sprain. Good rehabilitation and rest prevent the spread of spinal pain. Thank you for your attention.
Thank you very much, Dr. Kobashi, for this nice presentation. We're going to move to the next session. Our next talk is going to be by Dr. Cheng from China. It's going to be about osteoporosis and sarcopenia, the role of radiologists.
Thank you. Well, it is really my pleasure to be here and thank the organizing committee to invite me. And here I would like to share with you our vision on osteoporosis and the sarcopenia, what we can do as a radiologist in this field. So our body consists of bone, muscle, and fat, and of course many other things. But they are all connected to each other. When we get old, as you can see, the bone are lost, so we get the osteoporosis. The muscle loss, we get the sarcopenia. And when we get old, the fat increase, we have a problem of the obesity. As a radiologist, we have many imaging modalities. So we have we have X-ray, we have CT imaging with MRI, and for bone densitometry, we have DXA, and then we have QCT, and of course, we can use MRI to measure the bone, muscle, and the fat. So simply, we can use the X-ray to identify the vertebral fracture, which is important and very important for osteoporosis. And of course, with CT scan, and we can do the MPI, and we can clearly show you the change or the vertebral fractures. And of course, we can have MRI, and it will show you the change for the vertebrae, and you see there's a microfracture, and this is fat suppression sequencing, and you see this microfracture within the vertebrae. And this show you we can use DXA to measure the density of the vertebrae. We can use the QCT to measure density of the vertebrae, and of course, we can measure the muscle, and we can measure the fat. So as you can see here, when we are young and you have much bone, and when we get old and you have less bone, and then you have a problem with osteoporosis, and it will increase the risk for fracture. And the consequence of hip fracture is really a problem for human and for family. And of course, we can simply with the X-ray, and this AP view of the lumbar spine, and this left view, and you just simply look at the vertebrae shape, the height of the vertebrae, and you can clearly see this vertebrae and this one, they are decreased in the height. And of course, you can easily to do MRI scan, and this is sagittal T1, sagittal T2, and you can clearly tell you which vertebrae is fractured, and which one has the edema, and which one is very long-time, the old fracture, for example, like this one. So this is a fracture happened a long time ago, and now it's already healed. And of course, I think for some reason, the MSK radiologists are not care about bone density, and I don't know why, because I'm a radiologist, and I'm a MSK radiologist, and I have been working for this for more than 40 years. And I found that the BMD measurement actually is quite important, and I think the MSK radiologist should get involved instead of just don't care about this. Yeah, I think for this meeting, and we have a lot of talk about the clinic, and that's fine. But I think as MSK radiologist, we should pay attention to the BMD measurement. So we can use the technology to measure the bone mineral density and also bone structure and the body composition. And of course, the most often used, we have DXA and we have QCT. So this shows you the DXA machine, and this is a gene machine, and this is a hological machine. So you have a table, the patient lay down on the table, you have an X-ray tube here, and you can detect here. So you can measure the bone mineral density of the spine and the hip. And it comes out with the BMD value of each vertebrae, but it's different from one company to another. And for software problem, I think somebody proposed to use the T-score, which is use this formula, and you will come up with a T-score, and the diagnosis criteria for osteoporosis is use the T-score. But actually, the T-score, there's a problem. So it depends which reference database you are using. And actually, yesterday in the morning session, we have a nice session, and we have a nice speaker from locally, and he found it is very confused. In this hospital, they have one hologic machine, one G machine, and one patient did a 2 scan, get 2 results. And the problem is very simple. Just 2 machines, they are using 2 different databases, and it is very confused. And for radiologists, it is a very easy job, and we should help them. So here I hear you one example is from my experience. This is the same patient here. It is scanned with hologic, and later it's scanned with G machine and has 2 results, and one says it's okay, another machine says she's osteoporosis. The problem is simply they use different reference database, and we try to standardize it. It is not easy. And the QCT technology actually is really good. It is based on the clinical CT data, and we just add the calibration function, and simply you can just calibrate the CT value from the vertebrae to this phantom, and you can come up with an accurate measurement of the vertebrae body BMD. Actually, it is very simple. You have a CT scan, and you just have a QCT system, which consists of a quality control phantom and have a computer and have software. So, for example, you can see there, you have a fracture here, and of course, we do CT for them, and beside to the, we can see the fracture clearly. Of course, we can sometimes we can measure the vertebrae BMD at the same time, and we help the orthopedic surgeon to make a decision what is the orthopedic procedure. And of course, for BMD measurement, we always have to care with quality control, and we have a European spine phantom, and this is for QCT for a different hospital, different machine, and we do this to see the accuracy, and this is we repeat it 10 times and to see how stable it is. And of course, we have a Aggsr machine, and we have a DEXA machine. We have the QCT, and we measure the BMD, and actually they are measure different things. So this is projection, and this is the 3D volumetrically. So this is volumetric BMD, this area BMD, and they are really different. For example, for this case, you have the sclerosis here, and you have the calcification of the aorta. So if you use DXA, and this will increase the density, but with the QCT, there's no problem for the measurement. And I think for the radiologist, it is very easy to understand, and we should help the clinician to help them to solve the problem. So now for the diagnosis of osteoporosis, we have a DXA, and of course you have the minus 2.5 SD, and the problem I already mentioned to you, you need to check out which reference database you are using, and to be careful with that. Use QCT, and we have the criteria which is proposed by American College of Radiology. So for the spine QCT, we normally measure 2 vertebrae, L1, L2, or L2, L3, whatever you like. And if the BMD is below 80 milligram per millimeter, and it is the diagnosis for osteoporosis. And actually, we check this for China, for Chinese, and this works well. And we compare this DXA and with QCT, and we measured about 300 population at the same days, and you found out about 1/3 of they have a discrepancy between these 2 machines. So these 2 technologies really measure different things, and I believe the QCT is more sensitive to this regard. And of course, when the bone reduced and the muscle at the same time, when we are getting old and the muscle reduced, and it is also quite interesting for us an imaging technology, and we can help them to quantify or measure the bone muscle and the muscle area and the muscle fat. As you can see, this is a female, 75 years old, and this actually, of course, you see this degenerative change. But if you look at this is MRI, TY Agssr, and this is CT scan, as you can see, this paraspinous muscle, it is all infiltrated by the fat, no muscle at all. And this is CT scan, and you didn't see any muscle at all. So this is clearly very severe fat infiltration. And with the fat, and of course, we can use DXA to measure the whole body, and we can calculate how many percentage is fat and how much percentage it is the muscle. And again, with the CT image and the MRI image, we can easily to measure the fat and also the muscle. So for example, this is actually the CT image of the leg, and you see clearly how much the muscle and the fat, and you can calculate the density of the muscle, which indicates the fat infiltration. So why we are doing this is try to prevent fracture. And as I come from Beijing Jitai Hospital, which is a very big hospital for orthopedic, and we see this fracture, this old lady and old man, and it is really tragedy if we cannot help them to prevent the fracture. So I think as a radiologist, we should working together with the clinician and to provide the best care for our patient. So in summary, I think we have the bone, muscle, and fat, and many other tissues. They are all connected. And with age, the bone muscle decrease and the fat increase. So it will increase osteoporosis, sarcopenia, and obesity, all contribute to the quality of life. There are many image modality we can use to quantify them, so we can measure BMD muscle fat, such as Agssr, QCT, and MR. So I think the next speaker, Giuseppe, will cover more. And I think it's a time for MSK radiologists to pay attention to image evaluation of these conditions. And I think it is time for us to working together. So it is a call to action. And as you can see, many times I speak here and I speak in Agssr. I just think it is time for MSK radiologists to pay attention to these emerging conditions. So I thank you for your attention, and all welcome you to Beijing, to China, and to visit my hospital. Thank you.
Sir Chen, our next last session will be presented by Dr. Giuseppe Gualgliani about radiomex and image biomarkers in osteoporosis.
Thank you, Mr. Chairman, for the introduction. So, my talk will be facilitated since my colleague already present some concept. But anyway, the conversion of digital imaging into minimal data is the definition of radiomics. So we have to keep all the information that we can take from imaging and transform this in the big data. Because biomedical images contain information that reflect underlying pathophysiology, and that this relationship can be revealed by quantitative image analysis. So the aim of radiomics is extract quantitative feature, for instance, using our image technique, so we can extrapolate signal intensity, shape, size, volume, density, contrast enhancement, perfusion, transient time, texture analysis, and so on, from all diagnostic imaging, ultrasound, CT, MRI, PET, and put together this information with biomarkers that are specific to the patient into a cluster of biomarkers of that specific patient. So when we make this, we place this data in a big database and then combine this characteristic of that single patient with genomic data, and then the terms radiogenomic and other patient characteristics. So it's a modern view, modern aspect of we can interpret the modern medicine. And to give you some practical example, I start with this case because it's important to recognize that if we move to qualitative approach to quantitative approach of the disease, we reduce observed variation by manual annotation and increase speed of workflow. So it's necessary to reduce the intra and inter-operator coefficient of variation. Look at this case. We have two subjects having the same tumor in the anterior part of the cervical tract of the body. The first subject is, we call this responder, because after therapy, as you can see from the following exam, there is a disappear or significant reduction of the disease. In opposite, in this other subject having the same tumor, having the same age and sex, after therapy, the tumor still remain there. So, if we analyze the characteristics of these two patients, we can see that the tumor intensity, for instance, the tumor shape, the tumor texture analysis, and other parameters that I mentioned before are totally different. So, starting from the analysis of the information that we can take from images, we can create and separate two subjects, two groups, group 1 and group 2, and we call these two groups responder and not responder. And based on this characteristic, we can extrapolate the risk assessment, so we can have an idea of the probability, what is the probability of occurrence of the disease. So if the subject will have recovery or will not have recovery. So finally, the idea is to provide diagnostic, prognostic, and predictive information useful to generate hypothesis of the disease, to create an exact site for biopsy if necessary, to create a support decision model, and to confirm this with histopathological imaging. In few words, predict the right treatment for the right patient at the right time. In order to reach this goal, we need to go through different steps. And all the steps are listed in this schematic representation. So, acquisition of imaging, identification of volume of interest, segmentation of the volume, extraction, qualification, building database, and so on. So, you have to carefully follow all these steps in order to be consistent with your with how you reach your data. Why apply this concept in osteoporosis? Because, as you know, radiomics emerged in the medical field, especially for oncology, because you know the devastating impact of the tumor in the community. However, the technique, the same approach, can be applied to any medical study where a disease or a condition can be imaged using tomography. And you know that among musculoskeletal disorder, osteoporosis, in general, metabolic bone disease, due to its personal and economical burdens, have received increased attention. My colleague showed you before the number of the impact in terms of cost of the healthcare system and in terms of disability for the patient. So it's not necessary to repeat the definition of osteoporosis already given, but just to demonstrate that in order to have an equilibrium from the osteoblast and osteoclast activity, this condition, create new bone and reabsorb bone, should be maintained. If this any condition that can influence this equilibrium, then we have a decrease of the strength of the bone, and we have the prevalence of the osteoclast activity. That's why there is one aspect that taking into account the quantity of bone, and another aspect that take into account the quality of bone. So bone, both aspects are important because both of them determine the insurgence of fragility fracture. As you know already, the DEXA approach is the WHO technique recommended for diagnosis of osteoporosis, and this technique used the T-score and Z-score to evaluate the bone mineral density of every single patient. But based on this, the WHO organization created a cutoff level, and the result of the T-score based on this score system are differentiated in normal, osteopenic, or osteoporosis based on the fact that they are below -1, between -1 and -2.1, and higher than 2.5. But as already mentioned, this technique presents several limitations. The effect of aging on the spine, if you measure spine, and also another important and well-demonstrated condition is that nearly half of fragility fracture occur in non-osteoporotic individuals, as defined by DEXA classification. So it means that DEXA classification is not possible to apply it for all the population. And this came to the conclusion that other clinical factors, in addition to BMD alone, take a role in determining the risk of fracture, and these factors are independent of BMD. That came to the concept of quality of bone, because BMD is just a proportion of density of bone, but bone quality reflects the strength of the bone, the microarchitecture, the integrity of the network among the trabecula, and the integrity of the cortical too. How visualize this quality parameter? Because we know that with QCT, with better than DEXA, we can measure bone mineral density. But now, if we move from this quantitative concept to the qualitative aspect of osteoporosis, we should use different technique. And which technique? First of all, high resolution peripheral QCT at the level of appendicular skeleton, or multi-detector high resolution CT at the level of the spine, or some indirect method like trabecular bone score. Trabecular bone score can be applied on DEXA machine, and MRI, and some reflection of the X-ray on plane radiographs, the so-called dark field imaging that you can see later on. Just give you some idea about the possibility of this different technique. I show you an example of peripheral high-resolution QCT at the level of the tibia, showing the characteristic of the trabecula as well as the integrity of the cortical bone. And in fact, looking at this detail of the imaging, you can see that you can easily separate a normal bone compared to osteoporotic bone due to the lack of the integrity, the interruption of the network of the trabecula. And in addition to this, you can also evaluate the cortical aspect of the bone, because you know that cortical aspect of the bone is composed by 3 different elements: endosteal, intracortical, and superosteal. And using high-resolution image technique, you can go into details looking at this compartment of the cortical bone, because cortical bone also play a role in metabolic bone disease. It's not inactive bone, it's also active bone, and especially in fast loser, in high turnover situation, cortical bone is important to analyze and to detect. Here again, example, how can with CT you can separate the volume of the area of interest, separate the trabecular component, the cortical component, or evaluate all together. And this again is another more clear example how you can go into details and see how the cortical change during this advanced stage of osteoporotic. In this case, there is no cortical anymore, just everything is spongy bone. With CT, again, we can separate the cortical component with the trabecular one that is more active because it's more sensitive to the change of the vascularization. And again, using CT, we can have the volumetric approach on the spine or the hip, and separate the compartment of the cortical, trabecular, or having all together in 3 different planes: coronal, sagittal, and axial. And this can be also done using special software that can give you information regarding the height of the anterior, central, and posterior height of every single vertebra. Very sophisticated system that we can apply on this imaging. And naturally, the same thing we can do at the level of the hip, because you know how devastating are the consequences of the fracture at this anatomical site. And again, with this volumetric approach, using the volumetric spiral CT, we can separate the trochanteric, the femoral, and the total femur area. And especially using the CT approach, we can also measure other biomechanic characteristics of the bone, like moment of inertia, minimum, maximum moment of inertia, and we can measure the hip axis length, the so important geometric parameters which explain the reason why people from East country has less risk of having fracture at this anatomical site compared to the Caucasian living in northern part of Europe, because the shape, the distance of this axis length is significantly different in two study populations. That's why the risk is completely different. So, using CT and as well as MRI, these are the kind of parameters that we can extrapolate from data, from imaging. Trabecular bone volume fracture, bone number, trabecular spacing, trabecular thickness. TBS. TBS, already mentioned in the QCT section yesterday, is not a direct physical measure, but is a porous material status analysis parameter. So it's a parameter which reflects the quality of bone. And in order to show you the characteristic of this new parameter recently introduced in the field of bone densitometry, I show you these cases. This subject has a BMD 0.9 that is defined as normal. And the subject here below show the same BMD, 0.9. But as you can see from the specimen, this subject is normal, this subject has osteoporotic bone. So BMD taken from DEXA is not able to separate both, but using trabecular bone score, we have a value that is completely different among the two subjects. So TBS is a possibility to do that. Also, MRI show you the possibility to have the idea of the structure of the trabecular bone at the level of distal radius or at the level of the calcaneus, and can separate this in subject with having normal or subject without fracture. But going back to my conclusion, because I see the chairman here, so just few words about this grating-based X-ray dark field vector. So the capability of plain radiograph to impress film and the scattering effect give an idea about the density of the structure. This is a very new area that is under exploration, but you know, I like to give you an overview of everything, and this scale show you the difference in density of bone and the difference in color of this reflection system. And no time to talk about the union about bone and muscle, about we call the pleiotrophy, because this has been already covered by my colleagues. But just to give you an idea that since these systems work together, if we have a decrease in BMD at the level of the spine, the same we will have a decrease in the structure of the muscle, and we have an infarction of the muscle with fat. And if you compare these three kinds of subjects having normal BMD and normal structure of muscle and low BMD and osteoporosis, here you can see that the reduction of BMD comes together with the fat infiltration of the muscle. Also, there are some automatic systems to detect the fracture prediction and the so-called active shape model that, based on the model of the femoral head of the vertebral body, can able to predict the risk of fracture. But in conclusion, what are the challenges for radiomics? The reproducibility, because all retrospective radiomics investigation must be validated against a completely independent data set, preferably given by another institution. And this collection of data requires a prospective multi-center trials wherein the biomarkers is one of the primary components. And then we have the problem of big data, because for each patient, we should collect a lot of information. So another problem is the patient privacy, because these data are transmitted from one center to the other, so it's necessary to cover the identity of the patient, and the study should be done in a very homogeneous manner. The final slide is that in conclusion, we like to call this the P4 medicine. Why P4? Because it's predictive medicine, it's preventive medicine, it's participative medicine, it's personalized medicine. So radiomics is a new transversal subdiscipline of diagnostic imaging that can give a big contribution to development of this kind of medicine, that is the medicine of future, but we are already in the future. Thank you.
Thank you very much, Dr. Ghossebi. It's really interesting to hear about the future of medicine, something revolutionary. I just have probably 5 minutes for questions and answers. If there is any question from the audience. Good. I think it's already the end of the day. Everybody's tired, so we're going to move to the last session. It's going to be about the Best Paper Awards. So, Dr. I don't know. So that's going to conclude our first day of conference. And tomorrow we're going to start at 8. We just have an award regarding the paper for the Asian musculoskeletal.
Team for repeat. Prof. Kamishima will lead the team for the judges. We have 3 researchers and 2 by Prof. Mahesh Prakash and 1 by Prof. James Griffith. So the judges, we have Prof. Kamishima, Prof. Nizar Naqshbandi, we have Dr. Khamis Al-Mizahmi, and we have Tuhin? No, John George, as well as Stephen Wong. So these are 5 judges for the award, and then results will be conveyed to Kamishima, then the awards will be announced.
I want to go now. Okay, I'll finish this. 1 minute. अभी क्या लेके आएगा? सुधर क्या बात? इन्विटेशन पड़ा वो लेके आना। अच्छा कौन सा? ये तुम्हारा है? और आपको हुआ नहीं बाकी बैठा खैरो बैठा अच्छा
No, just close the door. No, I am the one who holds the key. Just, I have the key. Yeah, I'm going also. Just close the door. Just close the door, my brother, and close the light. Okay.
Class again?
Yes. When we finish.
No is finished?
For me.
Yes.
And
Also is
thank you so much. Thank you. Sorry.
That's okay. पानी आ जाएगा तो मैं चला जाएगा ये लैपटॉप क्लोज करके सारे सारी गड्डी करके चले जाओ ठीक है
ऐसे जाएगा इन तरफ का मेरा बोलो हाँ यही रखो
क्लोज कर देगा
कोई बात नहीं काम हो जाएगा टेंशन ना लो पासपोर्ट डेट है क्या जरूरी है पासपोर्ट डेट है क्या जरूरी है इस मोबाइल फेंक दिया
कौन सा वो ले गया
मेरा वाला नहीं मेरा गरीब आदमी हानि वाला कोई आदमी क्या करा गरीब
ये डालो उसमें तो ये सामान उसमें
तो हाल लगा क्या बस कर 2 मीटर का
नहीं ये सब चीज इधर तुम मत करियो पुराना चीजें तो मैं भूल गया तो बोलेगा भाई मैं तो भूल गया उधर हाँ मैं तो भूल गया भाई उधर
मेरा से कोई बात करो तुमसे हुआ हर आदमी के जो मेरा से
तुम्हारा कौन सी चीज नहीं हुआ
कौन चीज हुआ हाँ भाई एक नाम बताओ
हर बार होता है ऐसे होता भाई मुझे याद ही ना भाई उधर रह गया
कोई घूमने का कोई चीज नहीं
ये बंद तो ना करो
क्रिकेट का इतना बस हवा दूसरे घूम गया था
कौन तो वो तो हुआ नहीं भाई वो तो मेरे दिन ऐसे बोला लेकिन वो उसके अंदर ही था मैं टेम में डाल के रखा
मेरा नाम बताओ
तब नहीं हुआ तो आपको आता है
बताना चाहिए ना भाई
पाएगा
I can't prove, you know.
कोई जाना है गाड़ी आ रहा है मैं जा रहा है तुम ये
कॉन्फ्रेंस का काम पे आदमी बाहर से शहर से नहीं लेके आते हम लोग के
This row is very big, you know.
Because I don't have Chinese letter on my keyboard.
Oh, yeah, okay.
Hari dia semua. I see. So good, I didn't wait for tomorrow. I have to today. We'll communicate by email. Good luck for you.
So if you China, just email me.
I'll do that. Sure.
I need the China.
The gym, yeah. So, good to see you later.
Very
We're going to start the session now, so do you turn the lights or? No, you're not turning out.
Everyone is ready now? Okay, so we're going to start on the AIM-based scientific paper, our session. Okay, so are you going to start? No? Okay. We have 3 presenters today. Oh, 2? Are you sure? 3 persons. Oh, yeah. So, sorry. Okay, I don't understand it very well. So, the first one should be Dr. Prakash. Yeah? Okay. Okay, you have 2 papers. So, that one? Yeah? Okay, please go ahead.
Good afternoon, respected chairperson. I will be presenting my paper on the role of the diffusion weighted imaging in the diagnosis of osteomyelitis with the diabetic foot. We have an early experience at 3 Tesla MRI. This study was done in our institute. So we all know that the diabetes is a major health problem across the globe, and there are various complications. Diabetes there's a lot of complications can occur in diabetic patients, and the pedal ulcer, the lifetime risk is 25%, and half of the patients may develop the diabetic osteomyelitis because it's a breeding ground for the infection. There is significant source of morbidity associated with the presence of pedal osteomyelitis. And alarming 2/3 of patients who develop the pedal osteomyelitis eventually go to have a lower extremity amputation. So it's paramount importance to diagnose the entity as early as possible. Pedal osteomyelitis closely mimic the acute stage of the neuropathic arthropathy clinically, and here the imaging plays a very, very important role. We know that the various imaging modalities are available for evaluation of the diabetic foot, and by the various advantage of MRI is now the gold standard for the imaging of the pedal osteomyelitis, because it can evaluate the soft tissue, can evaluate the bone. So the MRI is the gold standard. So what are the features of osteomyelitis on MRI? That these are the T1, these are primary sign, T1 hypointensity, T2 hyperintensity, and enhancement. These are the primary signs of osteomyelitis, and there, if the secondary signs are available like ulcer, sinus formation, cellulitis, then there is a more chance of the osteomyelitis. But these signs are non-specific, like T1 hypointensity and T2 hyperintensity suggest edema. So many times it's a non-specific, and many times these patients underwent the biopsy for the final confirmation. So we thought probably can the diffusion weighted imaging helps in these patients. So aims and objective of our study was to assess the role of diffusion in cases of diagnostic osteomyelitis in patients with a diabetic foot. So we took 25 diabetic cases suspected clinically of osteomyelitis. The study period was 1.5 years. We did this study on 3 Tesla MR unit on Siemens with the dedicated 8-channel foot ankle coil with the gadolinium injections. The routine sequence were T1 and T2 weighted images and pre and post contrast imaging, and we additionally used the diffusion weighted imaging with the ADC map. The ADC, the diffusion was, the p-value was 0, 16, 600 and 1800, and the sequence was ecoplanar, the sequence. We took the measurement by placing the ROI in the abnormal areas, and then the ADC was calculated. The gold standard for the diagnosis was the bone biopsy with the microbiological or histopathological analysis in all the patients. So coming to the results, so we had out of 25 patients, we had the positive were 19 cases and the negative were 6 cases. If coming to the bone, which were the bones were involved, you can see here the first the metatarsal was the commonest bone involved, followed by the calcaneum. The main ADC value, if you see in the positive cases, is 1.35. With the negative cases, it's 1.64. So it's a significant difference between both the cases, positive cases and negative cases. And if you make the ROC curve, and if you put the curve in 1.57, then the sensitivity and the specificity is 80%, and the specificity is 80%. So let's see the one case is here. This is the case of diabetic foot. You can see there is a abnormal signal area in the fifth metatarsal at the base of fifth metatarsal, which is T1 hypointense, and this is T2 hyperintense, and then you can see the cellulitis also adjacent to it. In this post contrast image, you see there is an enhancement, the peripheral enhancement is there, suggestive of the osteomyelitis, and we took the ADC value. It measures 1.1 of the ADC value. In case 2, this is a case 2. Again, there is case of the diabetic foot, and you can see there is a definite ulcer is there, and there is abnormal signal intensity in the cuboid. And this is a pre-contrast images in the pre-contrast, and this post-contrast images. You can see there is definite enhancement is there in the cases of the osteomyelitis. Apart from that, the soft tissue, the inflammation. And when we measured the ADC value, it was 1.7. So we thought probably it's not a case of osteomyelitis, and it turned out to be a acute Charcot neuropathy, arthropathy, and patient was put it on the rest and other the treatment. If you see the cutoff, if you propose the cutoff value of osteomyelitis for the ROC is less than 1.5, then the sensitivity of the study is 88%, with the specificity is 80%. Coming to the discussion, we all know that overall specificity is 60 to 70%, with the sensitivity up to 80 to 85 or to 90%. There is overlapping features of the diabetic osteomyelitis and acute Charcot arthropathy, because they show the similar finding, T1 hypointensity and T2 hyperintensity. So it's difficult to differentiate between the basis of the conventional MR sequences. So, but it is important to differentiate osteomyelitis because sometimes they have associated diabetic nephropathy. So in those patients, we cannot inject the contrast because by injecting contrast, the sensitivity and sensitivity increases. But in those cases where the patient already had diabetic nephropathy, so contrast injection we cannot give. So those cases, the diffusion definitely can help. This is one of the study which was done by Rajek et al. There's nearly similar kind of agreement with our study, but this study was done on 1.5 Tesla and with the different parameters, and they have also put it the cutoff value approximately 1 with the sensitivity of 93 and specificity is 96%. The limitation of the study that sometimes we can have an excessive artifact also, and we have a limited sample size. Although we took the 25 patients, but still we feel that the 25 patients are slightly less if you put it this study. So to conclude, the diffusion is a diffusion-weighted imaging sequences is additional sequences which can certainly help to increase the specificity and sensitivity in these patients, and ADC can be used as an effective alternative in patients where the contrast injection is contraindicated, particularly because the diabetic patients also affect the kidney. So by that I conclude that study that the ADC was very helpful and diffusion was helpful to increase sensitivity and specificity. Thank you very much.
Thank you very much. Okay, so now open for discussion or after a comment from the audience. Yes, please.
How did they choose the ADC value of 1.04? Do you know?
How we take it is this is already generated, auto-generated map.
But the studies in the European Journal of Radiology, they also showed the same value?
They're slightly similar, but slightly less than our study.
Thank you.
Okay, so the machine utilized was different. The static magnetic field was different. So maybe the reason why the ADC value, cutoff value was different, right?
But the previous study, or this was same here? Yeah, definitely.
Almost the same.
Yeah, definitely.
Okay, please go ahead.
Dr. Prakash, I wanted to ask you, because you took it based on osteomyelitis, the diffusion and the ADC map. In case, because the two cases that I've seen, they have chronic Charcot, neuropathic. In case if the patient did not have a chronic, how can you differentiate, is there differentiation cutoff value between osteomyelitis and an active or acute neuropathy? Because both can have just bone marrow edema, but I wanted to know for the diffusion.
Yeah, definitely. That was the issue. We did this study. Like many cases, like still we have receiving the cases where there is a acute persistent chronic Charcot arthropathy with the diabetes osteomyelitis. So that was the issue that we faced, whether we can use the other method. But because the conventional MRI and this even particularly the contrast, they show the similar finding: the T1 hyperintensity, T2 hyperintensity, and the contrast enhancement. So, but if there is the ulcer is there, then usually people say that definitely is probably the osteomyelitis, but it's not always possible. So that's why people go for the bone culture after bone biopsy. So we thought probably if we can, the diffusion can help in this way, whether to go for this way or not, and we can avoid the biopsy or not. And particularly in cases where the contrast, we cannot inject the contrast, because contrast always increase the sensitivity and specificity by showing the peripheral enhancement and the enhancement of type of enhancement, the cellulitis, the abscess formation, because these are the secondary signs adjacent to it. Like if you have the ulcer, you can have the abscess formation in the bone, then definitely is it more chance of the osteomyelitis. Because this is the important thing to say whether this is the Charcot or.
But the value does not make a difference. That's my question.
Yeah, value makes the difference. Yeah, that's why in our study also and the previous study also, the value was different. For Charcot arthropathy, it was more than 1.5, and for osteomyelitis is less than 1.5. So in our study is 1.3, and for Charcot arthropathy is 1.5 to 7. So definitely there is significant difference. Statistically significant difference we found in our study. So, and even previous study they also found that.
Yeah, Mahesh, I wanted to know what was your expectation of the ADC value, because with the 1.5, the previous studies actually show the value when you have osteomyelitis to be less than 1. So is your expectation when you use the 3T that it would be as high as what you...
Yeah, probably because they used 1.5 Tesla 1. Second, the parameters they used different. And probably our people, our patients, they have a more of chronic charcot arthropathy also. So that may be these are the factors which may be associated with this kind of ADC value. Because we all know that the ADC value may slightly changes depend upon the sequence you are using and what kind of patients are there, and even maybe because of the MR machines also.
Well, the question actually I was asking is, with the physics, would you expect with the 3T to get higher values than with the 1.5?
No, I think we thought probably it should be a significant difference between this one, but the value, I think, even like if you consider the other areas also, the difference can be slightly different, value can be different, depend upon the auto-generated maps, ADC maps also.
So what was the difference between the B values, previous study and this study?
Yeah, we took the B value 0, 600, 800. Some people take a 0, 400 and 800. Some people take a 0, even 1000. So B value, it depends. People takes a different B values also.
Yep. Any other comment? Yes, please.
After implementing this diffusion-weighted imaging and the ADC values, does it affect the percentage of patients going for biopsy?
Yeah, definitely. After this one, we convinced the people, the clinician, that we can definitely use it in cases where the contrast cannot be given, particularly the renal failure patients. They are suspecting the case of the osteomyelitis, and if we do this one, then we are convincing them that probably this is not a case of osteomyelitis, and probably we are dealing with the acute charcot arthropathy. So in the hospital, we are convincing them.
Yeah, so
contrast is not injected.
What about the small percentage of or the small percentage of non-specific or non-specific, non-sensitive? This small percentage left. Do you keep it for the, you just can discard any thinking about this?
If they are clinical, they are very, very strong, very suspicious, they are very strong suspicion, then ultimately you have to go for the biopsy.
Yeah.
Biopsy remains the gold standard. So these imagings always helps, like whether we can avoid the biopsy or not.
Yeah, so you can filter some patients at least.
Yeah, definitely. So
and avoid the biopsy.
In that patient, yeah. For the clinician, we are just convincing them, and they say, no, we are definitely thinking of osteomyelitis, then ultimately patient
as long as they trust your conclusions.
That's this study also.
Yeah, is this a retrospective study or a prospective?
Prospective study.
Prospective?
Yes.
Okay, so in this case, the interpretation of the data is something different. Okay, so this is a research. So, well, my concern is the site of ROI versus site of biopsy. How do you adjust it, the two locations?
Yeah. We after the biopsy was done, after the MRI, and then we told them that if the lesion is, which is the location of the area which is abnormal, and then they took the biopsy from that particular area.
The ROI, size of the ROI, and also the repeatability, this time the reproducibility. So how many radiologists actually created the ROI?
Yeah, we did like we simply does that this is the area, and we have not done any reproducibility in this area, but we said that this is the area which is abnormal, and on MR imaging, and then they did the biopsy, open biopsy, and the result, after the result came out, then we assessed the whole thing.
Any other comment, question? No? Okay, thank you very much.
Thank you.
Okay, second and final presentation is by, no? Why? Oh.
There are 3 presentations.
Now I understand. Okay, so this is the second presentation by Dr. Griffiths. Okay, please.
Thank you very much, and I'm presenting this on behalf of my co-investigator Stephanie Yip, who unfortunately couldn't come to this meeting. And our topic was the ultrasound of superficial soft tissue tumours. Now, superficial soft tissue tumours, as you know, are very common and much more common than deep soft tissue tumours, but often difficult to diagnose clinically with respect to completely characterising a tumour. Ultrasound, because it's a superficial location, provides very good spatial and contrast resolution of tumours. It allows you to easily compress the probe and assess the sort of texture of the tumour. Also allows good colour characterisation of the tumour, and you can also, when you're doing the ultrasound, relate it to the patient's clinical symptoms. So ultrasound shows sort of good ability to actively characterise these superficial soft tissue masses. Now, we previously, several years ago, published a paper in Agssr in which we had 247 cases of superficial soft tissue tumours with histology, and the overall accuracy of ultrasound in providing a specific diagnosis, in other words, saying it was an epidermoid cyst or a lipoma, etc., was 79% in that paper, and it was performed over several years by 2 musculoskeletal radiologists. But that was a retrospective study, so what we couldn't determine at that time was the level of certainty of the diagnosis at the time of ultrasound examination. So what we did is we designed a prospective study, and this is the first ever conducted prospective study of superficial soft tissue masses with ultrasound. We included a larger number of radiologists, 5 radiologists, to reflect clinical practice, and we also tried to evaluate the radiologist's perceived level of confidence about the diagnosis at the time of ultrasound. Now, so the objectives of the study was to determine the accuracy of ultrasound in characterizing superficial soft tissue masses, the association between a radiologist's perceived level of certainty at the time of ultrasound diagnosis and the overall accuracy, and also, importantly, to determine the accuracy of ultrasound for differentiating between benign and malignant superficial soft tissue masses. Now, the study was conducted over a 5-year period, and superficial soft tissue masses were those defined as superficial to the investing fascia. So we excluded all lesions like deeply investing fascia, like ganglia or giant cell tumors of tendon sheets, etc. Also, the other exclusion criteria were the absence of a discrete mass, if there was any known prior histology, in other words, if the patient had undergone a previous biopsy, or if there was a recurrence of a mass at the site of previous excision, then those patients were not excluded. If the patient was known to have a diagnosis based on previous imaging, like MRI or CT, if that was able to characterize that, we didn't include those tumours. Also, if recurrent tumours were not included, and also if the patient just had cytology alone, fine needle aspiration, we didn't use that to make a diagnosis. The patient had to have some histological diagnosis. Now, the ultrasound, basically we include 5 specialized MSK radiologists with varying levels of experience. All patients underwent high-resolution ultrasound examination, either with a Philips Affinity 70 or IU-22 machine. And similar to clinical practice, we usually ask the patients their symptoms prior to ultrasound examination. We often, or nearly always, palpated the mass also prior to ultrasound examination. Now, so the formulation of the ultrasound diagnosis is based on a combination of clinical factors and the ultrasound appearances, which related to the location of the mass, the overall ultrasound appearances, the consistency of the mass, the color Doppler imaging, and the appearances of the surrounding soft tissues. but with respect to distinguishing between benign and malignant, these were the criteria that were used, and mass is more likely to be malignant if there was clinically a rapid growth of the mass. If there was presence of a known primary, then there was, that increased the diagnosis that this was likelihood that this was metastatic disease. If the mass was medium or large in size, if there was presence of moderate to severe intratumoral hyperemia, particularly if that hyperemia was chaotic in nature, and also importantly, if the mass had no similarity with the recognized ultrasound appearances of any specific soft tissue mass. In other words, if the ultrasound appearance did not look like a typical, like an epidermoid or a vascular malformation or a pilomatrixoma or any of the other known characteristic findings, then that would sort of raise our suspicion that could possibly be a malignant mass. Basically, the database consisted of basically a console on the computer in the ultrasound room. There was an Excel file, and the radiologist would add one diagnosis to the if he was completely certain about the diagnosis. If he was less than certain, then he'd say he'd add 2 to 3 diagnoses depending on his level of certainty, and you could say whether he was highly confident or probably, possibly, or unlikely or very unlikely about the diagnosis. So a very simple database, but we collected the data immediately after completion of the ultrasound examination. So overall, in the 5-year period, we had looked at all cases of 830 superficial soft tissue masses, and of these, eventually 28% or 234 patients had histology, and histology was acquired usually with tumor excision, but occasionally with biopsy or biopsy followed by tumor excision. But about 1/4 of cases eventually had histological diagnosis. So when you looked at the accuracy of clinical examination in those cases which had histological correlation, the clinical accuracy of making a specific diagnosis with respect to the tumor type was 33%. The overall ultrasound accuracy was 82%. And the radiologist was fully confident about diagnosis in 58% of cases. And in those cases where the radiologist was fully confident, then the radiologist was nearly always right with an accuracy of about 96%. So in other words, when the radiologist was fully confident, he was nearly always correct. Six incorrect cases occurred in that group. Let's have a look at some of those. This was an 87-year-old man with a shoulder lump. The radiologist diagnosed this to be a nerve sheath tumor, but the final diagnosis was a glomus tumor of the shoulder. Another patient here with a 42-year-old female with a wrist mass. The radiologist diagnosed this to be an epidermoid cyst. There was no hyperemia present on color Doppler imaging, but on histology it turned out to be an angioleiomyoma. Another case, a 36-year-old man with a heel mass. The radiologist diagnosed this to be a vascular malformation, but again, on histology it turned out to be an angioleiomyoma. And finally, another case, 76-year-old man with an elbow mass and who had inoperable HCC. The radiologist diagnosed this confidently as a cystic metastasis based on all of the features, but the final diagnosis was a hieradenoma. So with respect to differentiate between benign and malignant, in fact, ultrasound was extremely helpful. Of all the cases, both with histology and without histology, because all the patients were clinically followed up, so that's how we were able to exclude malignancy. There was about 1% or 12 malignant cases, and the ultrasound was wrong in only one of these cases. So in other words, the negative predictive value of ultrasound was extremely high. When the ultrasound says that there's no malignancy present, the ultrasound is nearly always correct. But the positive predictive value of ultrasound is lower, and that's several cases which were not malignant were thought to be malignant on ultrasound, but that was one of the differential diagnoses, but they subsequently turned out to be benign. For excluding malignancy, ultrasound was extremely accurate. This was the one case where ultrasound was wrong. Basically, the radiologist diagnosed as a calcified granuloma in the shoulder region, and histology was undertaken, and it turned out to be a calcified soft tissue metastasis. And at that time, the fact that the patient had an underlying tumor was not known at the time of ultrasound examination, and it was only after the excision that the patient had a radiograph, and that showed a radiation-induced sarcoma of the upper arm, and this was a lesion which the radiologist had undergone ultrasounds of 4 months earlier. So the limitations of the study was that only 1/4 of the patients had, 1/4 of the tumours had histology, but that's often the way with superficial soft tissue tumours. Often they're just followed up clinically. The tumours with less than certain ultrasound diagnoses were more likely to have histological confirmation. In other words, if the radiologist was not sure about the diagnosis, then they were more likely to excise that, so that might have lowered the overall ultrasound accuracy. Also, clinicians were not aware of the study ongoing at the time, so that might have lowered the overall clinical accuracy. And there was also possibly a referral bias with more atypical cases being referred for ultrasound examination. So overall, in conclusion, we found that ultrasound is a very accurate first-line investigation for characterizing superficial soft tissue masses when the radiologist can't be fully confident about the diagnosis, about the specific diagnosis in 57% of cases. And in this case, the diagnostic accuracy of ultrasound is extremely high. And ultrasound also has a very high accuracy and a very high negative predictive value of 99.5% in differentiating between benign and malignant superficial soft tissue tumours. Thank you very much indeed.
Thank you very much. So now open for question, comment, and discussion. Yes, please.
Thank you, James. Good presentation. You said it was a total of 5 radiologists involved. Did they do the scanning, or is initial scanning done by a tech?
Oh, no. The radiologist did the scanning in all the musculoskeletal scanning in our hospital is done by radiologists.
Okay, so during the course of the 5 years, was there any increase in confidence level, or were the radiologists blinded to the histology?
No, overall, I think even when we compared it, we thought the results would be more accurate compared to our previous study, the retrospective study. But overall, we found the accuracy was only sort of marginally overall increased. The overall accuracy of that study was 79%, and the later study was 82%. So why is that? Because ultrasound is very accurate, effectively, when for diagnosing the more common tumours like nerve sheath tumours, epidermoid cysts. In fact, if I could show you one more slide. This was another slide which I took out for the sake of brevity, but you can see this is the range of tumours that we saw in the study, and you could see that when you're looking at lipomas and epidermoid cysts and nerve sheath tumours, fibromas, ultrasound is quite accurate, but when you angiolymiomas, ultrasound is not very accurate, and we couldn't assess the really accuracy of all of these small other tumours because they're also, we're only at very few numbers. So that's the sort of spread of tumours which we saw in the study.
Okay, so did you actually look into the accuracy rates of the confidence versus the accuracy rates of the radiologists to see whether there was any learning curve over the 5 years?
No, we didn't see. Okay. No, we didn't look at that. No.
Okay, thank you.
Any other comment, question? Your presentation, this is the first line study, first line examination, namely the ultrasound is the first line, but actually dermatologists are looking at the tumor, right? So do you have any data, what was the feeling of dermatologists, especially for the 12 malignant cases?
the vast majority of these tumors are referred generally by orthopedic surgeons.
Okay.
And actually, interesting, 2 years ago there was a paper published in Radiology where they were using biopsy as a first-line investigation, but the point of our study is saying you don't need to do biopsy all soft tissue tumors. In fact, you don't need to biopsy the vast majority of them. If the radiologist is confident about making a diagnosis, then our study has shown that if the radiologist is confident, then there's a very high level of accuracy. In fact, the accuracy of ultrasound-guided biopsy, I was surprised to see in that study, was only 88%. Now, they didn't explain why they didn't get a complete, 100% accuracy, but the overall accuracy was only 88%, whereas the overall accuracy in our study of using just imaging appearances alone was 80%, so it's just marginally less than biopsy.
Okay, so any other comment? Well, actually, if you look at this paper in other way, you have only 12 malignant cases, yes, right? So, of course, you have total 800 cases. It's a lot, but only 12 cases of malignant. So, what do we think about this number? Is it enough to determine this is the radiologist diagnosis is reliable or not?
No, well, I mean the sort of prevalence of malignant superficial soft tissue tumors is around 1%, so that's the sort of number we're getting. So if we had to increase it to 10, 20, we'd have to scan up to 2,000 patients and 3,000 patients to increase the numbers. So it's definitely a limitation. We've only got 12 superficial soft tissue tumors, but if we were to increase that, if for every one increase in the number of superficial soft tissue tumors, you have to scan another 100 patients.
I know. So yeah, I'm just kind of unsure whether this can be a limitation or not. Yeah.
Yes.
Because this was not listed in the limitation section.
Yeah, true.
Yeah.
True. Yes.
Okay. What else? Any comment? No? Okay, thank you very much.
Thank you.
Okay, so now I will not make any mistake. This is going to be our second presentation. Yeah, by Dr. Prakash. When you are ready, please start.
Yeah, thank you. This is the role of shear wave elastography of the synovium to differentiate the tubercular arthritis from rheumatoid arthritis. This study was done in our institute. We all know that the various arthritis involving one or more joints, and they have inflamed synovium as proliferation and its presenting features. The diagnosis is usually based on the certain clinical criteria. Like in rheumatoid arthritis, we have the criteria, we have the psoriatic arthritis, we have a criteria, clinical criteria. But many times, the patient presentation is slightly atypical. On those cases, there is a diagnostic dilemma. The imaging plays an important adjunct role with the lab investigation to evaluate these cases. The imaging provides the information regarding the underlying synovitis, the total numbers of the joints, which joints are involved. The ultrasound and MRI both, they can detect the synovitis, but there is a lack of evidence, because how can we differentiate various kind of arthritis on the basis of the imaging? So we thought about that. We have the advanced imaging methods like the elastography. So can we use that elastography in case of to differentiate it to group of the arthritis? So we know that the ultrasound elastography is a newer technique which allows the quantitative and qualitative measures of the mechanical properties of the tissue. In other organs, there's already like liver, breast is already established. There has been a promising result in MSK imaging. We believe that elastography may help because of different pathologies of the rheumatoid arthritis and tuberculosis to differentiate each group of the arthritis. So our objective was to evaluate the role of shear wave elastography for the assessment of elasticity of the synovium of the involved joint in cases of rheumatoid arthritis and tuberculosis, and can be differentiated on basis of the elastography. This was a prospective study in the Department of Radiodiagnosis. The experienced clinicians carried out the examination of the patients. All the patients underwent sonography examination of joint with a 2D shear wave elastography. We used the supersonic explorers, the ultrasound system. Linear arrow, the 2 to 10 megahertz probe was used. The range of elastic modulus was between 0 to 80 with the color scale. The grayscale sound images were displayed alongside the elastography images. The qualitative, the data was recorded as a color scale. The range from blue for the soft, the hardest, and for the recording for the SW data, the standard ROI was placed in the synovium, and then we took the quantitative value of elasticity and the velocity expressed in kPa and millis. The appropriate statistical methods were applied. Coming to the result, that we have an average of mean thickness of hypertrophic synovium in both the group. The one group, rheumatoid group, has 3.1, with the tuberculosis was 4.02, and there is no significant difference between the synovial thickness on gray scale. But on elastography, you can see here that in the rheumatoid arthritis group, the mean the elasticity was 54.81 in comparison to the tuberculosis, where it was 30.483, and there was a significant difference between the two groups in the form of mean elasticity. And if you consider the ROC here, if you consider the 43.6 kPa, the sensitivity is 86.7 to specificity is 80%. Coming to the mean, the velocity and both the group, the mean velocity on rheumatoid arthritis was 4.2 in comparison to 3.9, and still there is a significant difference between the two groups. And if you consider the ROC curve, then the sensitivity, if you consider the velocity 3.76, then the sensitivity is 81.3 to specificity is 86.7. See some cases here. This is a case of the rheumatoid arthritis of the knee joint here. The grayscale, the color Doppler shows minimal color changes here, and this is the elasticity, the color map. You can see the blue changes here, and if you see here the measurement here, the mean elasticity was 80.4, the velocity was 9.3. Another case of rheumatoid arthritis of the wrist. Here you can see there is a lot of synovitis with the changes of the similar change in the erotic change in the bone. And this is the elastography map here, and you can see the quantitative measurement here. The mean was the 56.3 elasticity, and the velocity was is 4.3. In cases of tubercular arthritis here, this is a case of tuberculosis of the knee joint here. You can see the synovial thickening here in the case, the synovial thickening, minimal signal change in the Doppler, and this is the elastic, the curve here, and you can see the value here. You can see the mean value, the elasticity was 26.1, with the velocity was 2.9. So definitely there was a significant difference between the two groups. This is another case here. You can see this is another case of tubercular arthritis here. This case of the knee joint here. You can see there is a lot of synovitis here, and the grayscale, and the mean value here is the 23, with the value, the velocity was 2.8. This is another case here, the tubercular arthritis of the knee joint here, and the similar finding. The elasticity as well as the velocity was less than in comparison to the rheumatoid arthritis. To summarize that, if you put it the elasticity cutoff value 43.6 kPa, the sensitivity is 86 point, with the specificity is 80%, and if we put the cutoff value for the velocity 3.76, then sensitivity is 81, the specificity is 86%. Coming to discussion, that we know that the rheumatoid arthritis is autoimmune chronic systemic inflammatory diseases. The pathology, we know, there is a proliferative synovial proliferation leading to destruction of cartilage and the matrix. There is always a Euler and Agssr criteria to diagnose the rheumatoid arthritis. The tubercular arthritis is usually spread by the hematogenous. It characteristically is a monoarticular disease. Most common involve the knee and hip. And the other findings include the joint effusion, the osteolytic bone destruction. The issues here, like many times, they present the unusual clinical presentation, and those situations the imaging plays very, very important role. Also, so clinicians need to take the help of the imaging picture if we're not fitting in the particular criteria. We all know that the ultrasound is very, very good for evaluation of the joint, because it detects the synovium, the joint diffusion, and other findings. But definitely the etiological differentiation is difficult, whether which kind of the synovium is there, whether it is the rheumatoid or other arthritis or the tuberculous arthritis. So we thought probably that the elastography that can help in that way to differentiate whether what kind of elasticity is there in particular kind of synovium. So because the region may be because of the different histopathological finding, like in the tuberculosis, we know that the histopathologically maybe you can find the necrotizing granulomatous finding in the synovium, and the synovium definitely is slightly different from the infective synovitis in the rheumatoid. So definitely we thought probably they could both have the different histopathology of the synovium. So probably this can reflect on the ultrasound elastography. So we thought probably that way. And in the study also we showed that it was the elasticity as well as the value was different in both the group. So definitely, particularly like in the study, may not be useful where the rheumatoid arthritis is clear cut by the guideline Euler criteria. But many times sometimes the patients present with the kind of initially the monoarthritis kind of where the large joints are involved, and they are atypical presentation. On those situations where the clinicians want to have some role for the imaging, in those situations we can do the ultrasound and can help the clinicians and that way. The limitation of the study was to we have a limited number of the cases in the two group, one is 15 and 16. So to conclude, the elastic modulus and the velocity are useful. The elastographic quantitative parameters for synovial evaluation and can be useful for differentiate tuberculous arthritis with rheumatoid arthritis, which can mimic or sometimes is difficult to differentiate radiologically in many cases. But we need to have a larger group of larger patients study to definitely say whether this difference significantly hold true for more number of cases. Thank you very much.
Thank you very much. Okay, now open for question, discussion.
Thank you, Mahesh. I think, as you said, the sample is small and need larger study. Also, not only the sample, you need also other etiology that cause stiffness of the cartilage. The synovium to evaluate valid histography.
Sorry, I couldn't get you. You are asking questions?
No, just my comments. You need large group.
Yeah, we need a more number of cases. Yeah.
And also other etiology that causing stiffness of the synovium, not only the TB, because other etiology that can mimic and difficult to differentiate it between, and how confident you can differentiate this is a TB or caused by the rheumatoid arthritis.
Yeah, definitely this was the issue, we faced so many times, like patients presented with the similar kind of imaging features, the ultrasound, they have the synovitis, they have erosions, the similar body changes. So there's no way we can differentiate it, even the literature, there's no clear cut the things which can differentiate between the two kind of arthritis. We thought probably this may help in that way to differentiate two groups. So we did this study, and in this study we could get the results, and that with elasticity by using the elastography method. So definitely we have a the region, probably because of the histopathological changes in the both case different group of the synovitis. So we thought probably this may definitely help, but definitely we require more number of cases. But definitely this is the early experience we could get it in our study.
Mahesh, in the cases that you showed, did you find that there was more fluid effusion in the tuberculous cases versus the rheumatoid cases? And then, your ROI was only 1 millimeter. How confident were you that the ROI was not in the fluid versus and why such a small ROI?
Yeah. Definitely, the tuberculosis, like the largest joints, they have a more effusion as well as synovitis, and we differentiated the effusion by the grayscale as well as we put it the color Doppler. So by synovium will take a color Doppler, effusion will not take. So we differentiated that way, and then we put it confidently put it the ROI in the synovium only, not to go into the fluid. So otherwise the result may be misleading. So we were very sure that we are putting the ROI in the synovium, not the fluid. I think you are asking how you put it the ROI in the synovium. So as discussed, like by the grayscale, you know where is the fluid, the joint fusion, and where is the synovium. And if you are not sure about it, then you put it the color. So we put it the color, and if the color shows the power of color Doppler signal there, then definitely the synovium. So we put it the ROI in the synovium and not to the joint fusion. So that's why we put it in that way.
The other mention, you didn't mention that all this was this all in the knee?
What?
You mentioned synovitis.
Yes.
But you didn't mention which, was it just only the knee? Was it synovitis elsewhere?
Elsewhere, yeah. We took the knee, we took the wrist also. The joints, but we took.
It's just that you did not mention that in the slides.
Yeah.
Which joints you did.
Yeah, I think the cases I showed you here. This is the case of the knee here.
I didn't mean that. What I meant is I don't have a slide showing
this
where you did and how many cases. Yeah.
The left middle side or the right middle side. This is the wrist side.
Okay, the second question is, when you have different depth of area that you measure, did you find any effect on the value that you get? Because I believe the push pulse will work well in the certain depth of that you measure.
Yeah, definitely. Like they have been like already described in the literature. The elasticity can depend upon the various other factors also, whether the synovitis or anything which is adjacent to the bone, which is superficial or the deep. So definitely there is some variability can be there. But our study was, we are thinking that we will put it the ROI in the synovium, whether it is superficial or the deep. So if it if I able to see the synovium and then we are putting the ROI in the proper position, definitely will get the result. Yeah, we didn't measure that difference because we could see the synovium and then we put it the ROI. So we were not like measuring whether it is superficial direct. We thought probably we are seeing the synovium and putting the ROI there. We wanted to measure the elasticity. What is the difference between elasticity or not the superficial or the deep tissue?
final diagnosis was made by biopsy for tuberculosis?
Yeah. The biopsy as well as the FNACs.
So how about rheumatoid?
Rheumatoid with the criteria, the ACR criteria.
ACR criteria. In my understanding, our ACR 2010 criteria is for early diagnosis of rheumatoid arthritis. But your image was kind of advanced rheumatoid patients. And this is a prospective, conceptive patient study.
Yes.
So all the patients had a huge joint diffusion and synovitis in the knee. That is my question.
Okay, you are asking all the cases of the rheumatoid arthritis? No. All the patients were not showing, but we took because the clinicians were very sure about it by the criteria that these are the rheumatoid cases. By it's fitting in the criteria of rheumatoid arthritis. So we thought probably we'll see the elasticity of these patients and tuberculosis patient, because we have to prove by any method. So we did the FNAC and the biopsy in those cases to prove it.
Okay.
And for rheumatoid arthritis, we didn't have any the biopsy or anything, because there's various the criteria are there which are very, very good for the diagnosis of rheumatoid arthritis.
Okay, so I have one comment. For both of your studies, I'd appreciate if you can show the box and whisker plot, because this is a comparison of two different situations, conditions. So we direct to know the overlap of the for the both groups. So if you can show the box and whisker plot, that should be helpful.
Yeah.
Okay. Any other comment? So I think this is end of this session. Thank you very much. And please fill in the working format and please give it to me. Then the results should be tonight. Okay, determined tonight. Okay, thank you very much for your participation and kind attention. Thank you very much.
Thanks all. I think that we enjoyed today. Okay, we'll have the buses waiting for us in the nearby entrance of the North Tower. So I'm going with you there. So. The bus to the farm will be leaving exactly 7:30 sharp. We'll move to the farm from the hotel.
Thank you.